Thank you, Dr. B.N. Chakravarti, for inviting me. It was an insightful projection of the importance of maintaining the T helper 1 and 2 balance and its impact on the in vitro fertilization success rates. Hello friends, I'm Dr. Amit Patki. Today we will discuss the practical implications of Lotus 1 and Lotus 2 trials conducted with premenopausal women between 18 to 42 years of age with documented history of infertility. The aim of Lotus 1 and Lotus 2 studies was to substantiate the empirical use of 30 milligrams dydrogesterone, 10 milligrams administered 3 times daily for luteal support in IVF, and to demonstrate non-inferiority to 600 milligrams of micronized vaginal progesterone, 200 milligrams administered 3 times daily, or 8% micronized vaginal progesterone gel, which equates to 90 milligrams daily. The results demonstrated that oral dydrogesterone is a viable alternative to 2 main types of micronized vaginal progesterone, either gel or capsule, for luteal phase support in IVF patients, and dydrogesterone may replace micronized vaginal progesterone as a standard of care owing to its patient-friendly oral administration. Both the progesterones had comparable safety and tolerability profiles. Overall, the robust Lotus 1 and Lotus 2 studies identified no new safety concerns associated with using oral dydrogesterone, and no link to congenital malformations could be identified. Therefore, dydrogesterone has the potential to induce a paradigm shift for luteal phase support in the estimated 1.5 million women undergoing IVF each year. I was fortunate to be part of the Lotus 2 trials and an initiator for both Lotus 1 and Lotus 2 trials. These trials were conducted not only in Europe, but in Middle East, Far East, India, and China, taking a large amount of population diametrics into concern. I think the Lotus 1 and Lotus 2 have firmly established that dydrogesterone can replace a micronized vaginal progesterone in luteal phase support in IVF treatment owing to its patient-friendly oral administration. I now hand over the session to my fellow colleague who will speak on the story of frozen thawed embryo transfer and the missing corpus luteum.
I wish to congratulate to all our mentors, conveners and co-conveners of the workshops for making an excellent scientific program for these workshops. I would like to thank to all our listeners, and I hope at the end you will take home important messages which will help you in future practice. I declare now the workshops open. Long live IFS.
Dr. Abha, please start.
Yeah, good morning. Welcome to the workshop of the 16th Annual Conference of Fertivision. This is the first virtual global congress. It involves our delegates as well as speakers all over the world, and organized by Indian Fertility Society. I'm a part of it, very proud to be a part of it. And this is one of the pre-Congress workshops. And I think it is very, very important because it speaks on IVF during COVID. COVID is a pandemic which was declared by World Health Organization in January. And then in March, they declared this as a pandemic. So from an emergency of international concern, it became a pandemic for the whole world in March. And suddenly we all ART centers grew afraid of the situation, not what the man and woman or those people who are already there on this earth would face, but also the unborn child. And therefore, everything came to a big shutdown. The whole world closed its ART centers. And as of November 22nd, 2020, more than 58 million cases have been reported to have happened of COVID-19 across the world, out of which about 1.3 million don't survive anymore. They have been lost due to this pandemic. Having said that, in the first 3 months, COVID came to such a big shutdown everywhere in the world. The numbers from thousands came down to zeros. However, we still celebrated the World IVF Day in September with the birth of Louis Brown. And Indian Express wrote that in this quarter, that was April, May, June, just about 1,000 cases were done, whereas normally every quarter saw about 50,000 cases in India. So this was the status, that about 1,000 very, very important cases in a big country like India could still be carried out. But then American society also woke up, the ESHRI European society woke up, and the British society, and so did the Asians wake up that no, this pandemic is going to stay, it is just not going away. And in July, we started revising what we thought in March would sort of end in a few days. In July, we thought we are going to live with it. So we had to come back with our services. And therefore, our experience sharing is just about 4.5 months. 4.5 months have brought in a lot of restrictions to start with, and then we became lenient with our restrictions. We started taking our patients more readily. We have learned now, or we are learning to live with COVID-19 infection. The American Society for Reproductive Medicine said that they advise the clinics to be flexible and recognize the status of their local transmission rate, medical conditions, and any impact that reopening their doors to their patients may have on their community. Having recognized that, they have left loosened ends. They've loosened all the ends of restrictions, and they said all centers can follow their own norms. And most clinics resumed IVF from July onwards. And thus the age of our experience of working with COVID-19 is just about 4.5 months. And today in this workshop, we are going to share our experience of living with COVID with the world of IVF. We are all getting together, we are giving solutions to it, we are finding ways to cope, and we are trying to save ourselves and our patients from getting into the peril of contracting COVID-19 while they come to the hospital or while they take treatment. I welcome everyone, all delegates from our country and across the world who have joined this workshop. Please attend this workshop. This is one of the most important workshops in today's pandemic because it will guide us through many obstacles which a lot of us have been facing. Once again, welcome everybody. Thank you very much for attending this workshop.
So, thank you so much, Dr. Abha Majmudar, for the very good welcome address. Now, this is our 2020 visions, and I know that I must congratulate all the people, those who worked hard. I must congratulate our President, Dr. Sudha Prasad, and the other team, those who are joined to making this workshop successful. So without wasting time, I can just say that COVID, already Madam introduced that COVID is a very dynamic situation which is arrived in our society. And this is a most important workshop. And we are sharing our whole experience that how to work with the COVID. And to be start with, I will like to introduce our MOC. I think so. I request Yogita Dogra that please hand over the mic and just introduce the first speaker because we are running short. So we can start with the first lecture of this workshop, Dr. Bharti Thore Patil. Yogita?
Yes, sir. Good morning, sir.
Yeah, good morning.
So today, a very good morning to all. We start with today's academic endeavor, and to chair the first session, We have with us Dr. Geeta Radhakrishnan.
Good morning, everyone.
Dr. Geeta Radhakrishnan, Madam
Yeah,
is
I'm there.
Deputy Clinical Director and yes, Madam is Deputy Clinical Director and Academic Coordinator, Women's Center and Hospitals, Coimbatore, Tamil Nadu. Dr. Sheetal Swankar, she is Medical Director, Morpheus, Mumbai. Dr. Prabjot Kaur, she is Scientific Director and Senior Consultant, Divine India IVF Center and Research Institute for Human Reproduction and Senior Consultant at Guru Nanak Hospital, Karnal. May I now request Dr. Geeta ma'am, please to introduce our first speaker, Dr. Bharati Dhore Patil.
Very good morning, everyone. We all know Bharati Dhore Patil. She is head of the department, She Hospital, Pune, and she is an IVF consultant at Nova Fertility Center at Pune. And who doesn't know Bharati? And we start the day with Dr. Bharati's very interactive lecture on how COVID-19 will have a long-term impact on our IVF sector. Dr. Bharati, please, you can start sharing your screen.
Thank you very much and good morning to you all. At the outset, I would like to thank the Fertivision 2020 team to invite me for this lecture. Congratulations to Dr. Sudha Prasad and Dr. Anina Malhotra, Dr. Umesh Jindal for this wonderful virtual global conference. And I would like to now share. They've given me the topic for long-term impact. As Dr. Abha Majumdar just now said, we are just 4.5 years, half months old in this COVID situation, and in this situation, we really nobody knows how things are going to place, how we are going to have the impact on our uh, practice. Just a minute. So it's not coming. Hello from the
And please share.
yeah, that's what I'm seeing. Is it coming? Hello.
Yes, yes, yes.
Showing,
Now you,
it's showing,
now you share your PPT.
yes, yes.
See,
Yes, yes. Now you make the PowerPoint. Yes, ma'am. That's fine.
it's okay. Na?
Okay.
Yeah, that's fine. So how COVID-19 have a long-term impact on IVF sector? So we truly speaking, to be very honest, we really don't know. Because how it is going to go ahead and how it is going to make a practice different, how it is going to affect the patients or our unborn children or embryos, we truly don't know, but there is a bit speculations about it, like what we can look at. We all know that these are the group of viruses and they are club shaped. This protein spikes which you see around that protrude from the viral surface and creates an appearance of corona, and that's why it is named as a corona virus. Coronavirus COVID-19 is an infectious disease caused by newly discovered coronavirus. Coronavirus are the group of viruses that causes respiratory infection and usually are mild, but including some cases of common cold. And we all know that first identified in December 2019 at Wuhan, China. What happens actually with this COVID or the coronavirus is the spike surface glycoprotein of the virus that binds to the host via receptor binding domain of the angiotensin converting enzyme 2, that is ACE2. This is very important because we will know why this is important, because the entry point of the virus is through this. So where they are abundant in the type 2 alveolar cells, and that's how we see the respiratory infection more in these patients. And we have to know that when it comes to the reproductive system, how many receptors we have. there, and how can this virus can enter, and that will have a impact, long term impact. So 10 to 20 times it is higher affinity compared to SARS-1 virus, which was initially came to us. So after this two, the virus attaches to the target cells, this viron releases the RNA into the cells. And this is the way that replication of the virus will start, and that starts infecting more cells. So COVID-19 produces this several virulences factor and promotes shading of the new viron, and thus this is actually infect the host cells and inhibits the immune response. So we must understand that this is COVID-19 is immune mediated rather than pathogen mediated. So this is a very important statement, that this is actually affecting or attacking your immune system, not exactly only the pathogen mediated it is. And that's how the long term impact would be on the IVF practice, the number of cycles, the economy of it, and how can you reduce it, and how can you make it still cost effective to the patients by taking all the precautions. The second impact would be patient's perspective, like what would be the patient first fear, then taking care of themselves, and then fearing about their own gametes and the embryos which have been going to be in the laboratory, or if they get pregnant, how that is going to have a long term effect. This effect, that is a patient's perspective. And the gametes perspective, when you come to a cryopreservation of these gametes, we do not know how it is going to affect when they actually come out and they come as a live babies. We do not know how these gametes, because we had one patient who had COVID positive, and she comes back to us after 3 months, and we 2.5 months, and we started the treatment. We did not know, we got a very bad quality oocyte. Now we don't know whether it is because of that or the patient has inherent problems. So these all are query in the mind, so we really don't know what are the long term effects of this COVID. So just to get the glimpses, like what can be the effect, or I went through this research, all the literature, but somehow I could not get anything which can be predictive of long term. We could get that ASRM guidelines, like what should be the patient management, what should be clinical recommendations, how can you deal with the gamete or the laboratory or your patients coming in to you, how can you protect yourself and to protect the patients. These are the key recommendations from the ASRM, but this is all for the patient guideline. It is not for the long term effect, how it is going to affect. So they say suspend initial new treatment, whichever the very important or the time pressing patients, like age or the patients, they could be taken. Consider cancellation of all embryo transfers, fresh or frozen. Patients in cycle actually requires urgent stimulation or a cryopreservation, only those you can take. And suspend elective surgeries and non-urgent diagnostic procedures. So minimize in-person interaction and increase the utilization of a telehealth. Then coming to this very interesting article, which is in 2020, was been picture of COVID-19 impact on the EVRMA fertility treatment clinics in Spain and Italy. Very elaborately they had done. Antio was been one of the author. What they said, chronic viral disease have been a matter of concern for the practitioners of ART. There may not be lot of information about the COVID-19 and fertility, so everybody is accepting that there is not lot of information and long term effect. According to this issue, latest update from ESHRE stated that any risk of viral contamination to gamete and embryos in the laboratory is likely to be minimal, because repeated washing steps which we take at the time of IVF for the culture and the freezing protocol probably will not have that bad risk of viral contamination, but still we do not know. Even with no specific data available, it is assumed that sperm, oocyte and embryo do not have the receptor for the COVID-19 to enter. So they are unlikely to be infected. That is in ISHRE 2020. So these all statements agree with the previous publications, and in which it was been concluded that there are not viral sequences after culture and vitrification of the oocyte and embryo derived from the seropositive patient. So they looked at the seropositive patient and could see that there is no contamination. So ASRM have classified again certain reproductive medicine procedures elective and non-urgent. So this definition has generated lot of controversy. Which is elective, which is non-urgent? Especially patients who has advanced maternal age and the diminished ovarian reserve, probably we can take them as a urgent or on the front line of the treatment. So this, in the line of this position, Italian Fertility Society actually and IFS, we think that limiting indefinitely the access to ART treatment to these patients will certainly affect their chance to conceive once this outbreak ends. So we have to rethink and go ahead with these patients. Further approach to consider the age as an emergency time sensitive factor and infertility as a disease to resume the treatment for obtaining oocytes and euploid embryos, although embryo transfer could be postponed for later. So they say probably we can go ahead and retrieve the oocytes, and maybe you can do PGS for this patient, look at the euploid embryos and can be frozen. Maybe transfer can be done little in the later stage. So at this point, when the occasion arises, we would like to highlight the importance of transferring the embryos one by one during this period of pandemic, with the aim not aggravating with the twin pregnancy the condition of a pregnant woman who can be affected by the virus. So this was the strategy by EV, the Italian and Spain group, and this is how they went ahead for their strategies. So what could be the impact of once the patient becomes pregnant on the pregnancy? This was again in that guideline. So interim guidance has been issued by WHO and CDC on managing COVID-19, which actually says probably uh, we have to look at the patients very carefully, but none is been seen very dogmatically that this could affect the pregnancy and the children coming after the COVID positive. So the last two slides, how COVID-19 transmission occurs, and with this we will come to know why we are not much worried. But looking at oocyte and the sperms, we have to think about the gametes in long term. COVID-19 shows marked predisposition to the alveolar epithelial cells that we all know through this enzyme 2 receptor entry point. Consequently, COVID-19 cannot enter the cells which do not have ACE2 on the on the surface. Now, ACE2 was reportedly detected in Leydig and Sertoli cells and the spermatogonia of the human testes, theca, and granulosa cells of the human ovaries. So this is where is the catching point. The mature human spermatozoa and oocytes are not having the ACE2 receptor. So if once they are mature, you don't have the ACE2 receptor. There are no reports of vertical transmissions from the parents to children concerning the SARS outbreak 2002 and 2003, which also uses ACE2 as a main entry point into the cells. And there is much controversy concerning the vertical transmission of the COVID-19, because we have seen, I myself have an experience of almost 15 patients to be delivered, and the babies are not having any COVID transmission to the patients. So looking at the whole scenario, I'm not in the position to tell you all what could be the long-term impact, which is still debatable. And I think that's how today's workshop is meant, and we will learn many things. We will take many opinions from the faculties. Dr. Abhay is going to be in the moderating the panel, which is going to give us the many insights what we can do now, and the time is going to tell what could be the long term impact of COVID-19 on the IVF sector. With this, I would like to thank the Fortivision 2020 team and wish them all the best for the main conference. Thank you very much.
Thank you so much, ma'am.
आउटलुक से लॉगिन करता हूँ। हाँ। डालो अपना जो भी अकाउंट कर दी।
Sina_Suchma thought.
Thank you so much, ma'am, for such a nice lecture. May I now request Dr. Prabjot Kaur to introduce our next speaker, Dr. Neena Malhotra.
Yogita, can I just start in case they have lost touch? I can start because we should not waste time. I think if,
yes, ma'am. Sure,
I
ma'am.
think let's not kind of get into wasting for people waiting, because we will be running late and we have to hand over the session. So I think I would introduce myself. I am the Secretary General of the Indian Fertility Society and work at All India Institute of Medical Sciences. And I think I would, at the outset, I would thank Dr. Abha, Jayesh, and Ila for having me let in to speak on punishment management and guidelines to follow in ART during this unprecedented situation, the pandemic of COVID. Perhaps I could say that I have been involved in making the guidelines, the joint guidelines from the right scratch in for the 3 societies, and I was very much proactive. But I think this is what is now story and history, what we'll create. But as of today's morning dashboard on the Indian Express or every in a newspaper in the morning, this was what the morning paper gave us, the data on COVID. Of course, we had the first case coming on March 11th in India, and then we moved further to know what this is. And this is the statistics as of today on the 29th of November. So having said that, I think this is the way we would just sort of have a base of how COVID-19 is going to affect human reproduction, and particularly fertility, infertility, and the management in the IVF for services, and how can we tailor make these services not just for our patients, but for ourselves and the team. As Dr. Bharti rightly pointed out, the presence of ACE receptors is the one which is important, the ACE2. And we've learned that this is the one which is present perhaps on the Leydig cells in the testes, but the role on ovaries is rather dismal. Again, interesting that has come out from the ASRM publications is that they are perhaps more prominent in the male reproductive system. Unknown if SARS is going to be affecting the receptors in the female reproductive system, unknown to impact the oocyte quality, embryo development. And also we are still naive and we do not know that what is going to be the extent of exposure and precautions that we need. To the extent that we still need investigation. And I think this is a must read, which is a paper which has come out in the Fertility Study on Human Reproduction, really an eye opener. And I will just share you that from March 17th until today, there are 10 updates that have come from ASRM every month. And surprisingly, where Dr. Bharti pointed out that they stopped and put a complete halt, they are moving ahead and they're not even advising, screening for SARS. The COVID screening is not part of the game in ASRM. Clearly, if you look at this, it's an infection which may adversely affect pregnant women and the offspring. And we are still not very sure whether vertical transmission is taking place, because those who had been pregnant very early in March have not shown many sequelae. But then we are going to learn, because we are the ones who are involved in creating embryos and making babies. So we have to be very precautious. So I would just really go straight, because, when we are in fertility services, we sort of freaked out when we got, and of course we're handling semen, we're going to do semen analysis. And that's how we looked at. I think we freaked out with this JAMA paper, which said that, yes, semen tested positive on coronavirus, and even from the dead, they got coronavirus from their testicles. And then there were papers which came from Italy. And if you look at the latest, which is coming in August, says there's no evidence of SARS-CoV-2 in the semen for male recovering from coronavirus disease. And having shown to share this, that we also have an intramural grant, and I've already collected, semen from 31 men with mild and moderate disease from admitted in Jhajjar, and we've not been able to isolate the virus in the 25 samples that we have tested. So again, I think our data, perhaps you're going to add also on the cervicovaginal discharges, because we're looking at diet. So couples were admitted, so whether it's present in the women. So that's what our experience is the same from the small grant that we have. Really a concern, because people are of the thoughts that like any viral infection, this could also lower the semen counts. And that's also part of our second part of our study, which we are looking at. And I think this paper again in the fertility sterility, very recent, I think this is August or September. What they came across when they look at the numbers, whatever numbers they had, they just had 18 samples from men who had recovered. And of those 18, they went on to look at 2 who were active infections. So very small numbers, and that's what is getting published. Clearly says that who have mild disease is unlikely to alter the sperm functions or the semen parameters as compared to moderate, where they showed a transient changes in their counts and also motility. So I think we would really need data. But the very big concern is what we kind of freaked out, that absolute no, don't touch semen, let the men not come. I think we're going to realize that there's so many prostaglandins in the seminal plasma that the poor virus will be killed. So I think that infectivity bit is getting more, we're getting more knowledgeable. Yes, definitely when the man is infected, better not do the semen sample at that point in time. And obviously the man will not come for an IUI or for an IVF while he's really acutely infected. So I think that again obvious, because on the recovered samples, they did not find a change. Of course, as Bharti said, it's ESHRE, SRM, and you can look at every society has put in a guideline. Then want to share right from SRM, SART, ESHRE, BFS, British Fertility, and of course, the joint statements that have come. But whatever said and done, I think we also were very naive when we started making the guidelines in May and published in 26th of May, when the 3 societies got together. But I think the guiding principles for anybody of us in the times to come, and also in the current situation where we got a little bit of more understanding from whatever things have shaped up, is that we've got to be looking at the well-being. We've got to make proactive mitigation strategies, very important, counsel our patients who really want to go. And of course, every unit has to have a robust SOP and plan in place. Of course, this is what the joint societies together came up. And this was what was released. Basically, we really realized that we have to resume because there was a complete lockdown, and how do we really guide people? I know that this has been a little bit of kind of just the beginning, but we begin from the A, B, but we really have not reached the Z, and how far we are reaching in writing the Z or the end of the story, we really don't know. But I think one can go on the net and read the guidelines, and I will not spend time because paucity of thoughts, because this is how the guidelines in. They're all very, very put up there. I don't want to read, but of course, very important thing was again the discussion, agreement, consenting, triaging, all those parts are there, adapting your, and a very important thing was a code of conduct, which was there, which is all there in the thing. Of course, I will again not go in detail, but consenting is very important because there are potential risks of, and every couple will be apprehensive. Will it go to my baby? Should I be the right couple to go in, and can I postpone the treatment? Will I be in the right phase if I test positive? And of course, I think as we've understood from the labor ward, which are going back to back, we are not stopping delivery and pregnant patients. I think triaging and screening has been very important, which is again to be done in consenting, the couple being told on everything, how emotionally they're involved, what they've got to test. And that is all very important. Again, I think we've understood, I think ESHRE still believes on ELISA guidelines and ELISA testing on antibodies. We are still not in a position. Of course, we have also got more understanding on the testing, moving from the RT-PCR. Now we are triaging with the rapid test, but believe me, rapid antigen testings are not the way forward to sort of take your patients on, because they have got a very, very high false negatives. So of course, I think all this part has to be talked in detail about the husband and the wife, and also when they're embarking upon it, what is the importance of maintaining an isolation at least 2 weeks prior, because it's not about them testing positive and then being cancelled. It's the way we will look at it. And I think now we've learned that we don't need to kind of close the facility as we thought initially. I think we are wiser on our understandings, and we also need to update our kind of guidelines. Of course, as I said, RT-PCR is the one which is really mandatory, because it is the one which helps us decide whether we will move forward. And because when I share experiences, there are a lot of clinics which said that we started with the rapid antigen because it works out cheaper. The government is providing in Delhi, but when the patient went on the day of the womb pickup, she was RT-PCR positive. So I think these things are very, very pressing issues, which I'm sure Dr. Abha is going to deliberate. Needless to say, the importance of teleconsultation, which can save you not only from, and of course help you the mitigation and the risk of spreading the virus, but of course all those things are very important. And this is one place where I think getting semen samples from home is truly respected and acceptable. Of course, consenting and the signatures are very important. As I said, I think every clinic will have to tailor make. What SOP is made at AIMS will not apply for somebody in Ahmedabad, or for that matter, anybody who's having a solo clinic. Needless to say that you have to keep your policies in place, keeping what your government guidelines are. And what are they? Because at the time when we started making the guidelines, facilities for RT-PCR were not even available in Mumbai, Ahmedabad, and the cities where the number of pandemic cases was so high. So I think all those things need to be taken in place. And I don't think anybody can give you that I can make one guideline that fits all, as the SRM has done. Of course, I think what everybody has to do is rearrange your clinics and restructure and reshape your places, because we're saying that patient waiting areas right to your scan rooms, everything needs to be really taken care of. Very important is the state staff arrangement. And I think the labor wards as at, I would say, has really given us an insights. Of course, we said that husbands need not come, relatives need not come, and that's very, very respected. Even when we see our places in the hospitals, when we are doing the OPDs, I know we are not being rude, but we have to be very careful, and distancing and all is very important. Of course, a very important thing is when you're starting is the thing which people had, the traveling or the, flying embryologists have really lost their business, I would say, because you have to work on a backup team or a mini team, because it's going to be where 1/3 of your team comes, and we have to work in shifts. So all those things have to be in place in any unit which is placed. Now, of course, prioritization is important. We knew that earlier. We were saying that just do cancer patients, but I think what we said, third-party reproduction not to be honored. Maybe in a couple of months we say yeah we can, but as of now, we would really be important to identify patients who are at high risk, should not be taken, particularly who would read a kind of multidisciplinary team management, because we are short of staff from all sides. Beginning our clinics and the stimulation protocols, again, humbly we said go in for a protocol which is simple, and antagonist protocols for IVF cycles with a fixed protocol, so that you just call them fewer times for a monitoring, like maybe just call them on the baseline scan, then call them on 6 or 7 days after stimulation, which would perhaps be day 8 or day 9. And then maybe if you can afford, just keep them to 3 or 4 monitoring as against what we were doing previously. Likewise, I think whatever you do, whatever cycle you do, make sure that you don't land up in cancellations or land up in OHSS, because that is something which is going to be very nasty, particularly in a setup where the presentation may really overlap between an OHSS and a patient with COVID positive state. I think what's very important is of course, oocyte retrievals. Again, the guidelines are in place. I will really not spend time in detail on that. As of now, or should we go in for fresh transfers or frozen? Because in the beginning we said go in for freeze all. We really do not know. But I think we are still in the process to understand. But most units, as I was talking to my colleagues, are freezing the embryos with separate tanks in place and perhaps would go. A question that's really asked to me when I talk is, what is the oocyte quality? And people do share that the quality of oocytes and the number of oocytes for the patients that they're doing are lesser. I really can't say because I haven't started fresh. We're doing frozen embryo cycles only for the embryos generated prior, because I work in a hospital which is a purely COVID hospital, and the administration won't allow us to really move forward. But I think this is something which needs to be dwelled, and that's where we have to really kind of update ourselves. Again, I think troubleshooting is an important area for which everybody will have, and I think common sense would prevail if there's a troubleshooting, because people would still want to go ahead if their patient is positive, or I think that's what is a big chance one would really take. But yeah, definitely if the husband is positive, freeze the eggs. If any of the partner turns positive or develops symptoms, I think we should cancel and go in for freezing of the embryos. Now, as I said, policies are to be in place. I will really not go say, of course, the lab policies have to be again in place. Won't really go in detail. But what I would say is that anybody who's wanting, as per guidelines for most societies, that we should have our tanks separated, because we really don't know, though we are doing excessive washing, cleaning, clearing with the embryos when we are even doing all the process of handling the gametes. And of course, what we are saying is limits the numbers. Don't be in a rush, because we still are we are learning a lot. As for PPE guidelines, they're all there. And of course, reform the code of conduct. Now, one thing I just want to just say that what is the level of PPE is what everybody asks us and what the guidelines say. I think for the lab, it's very difficult to work with shields. And so what face masks, which are FFP2, are the ones which are recommended. I'm sure we are all taking our patients who are COVID negative in the theater. So really, should we wear the complete, don ourselves and gown ourselves? I think is a question which we can be sensible. I think, and we're doing cesareans in COVID negative patients, or we are doing, office procedures in COVID negative. I think those are the way we will have to look, because there's definitely an inherent cost that will be involved in whatever extra we do. Now, I just want to share you here, and just 2-3 things before I leave. I think I just have 5 minutes and there'll be questions. Look at it when March 17th, the SRM came. Again, they were so naive when they gave this our first update on the 30th of March, which was applicable until April. They said suspend all treatments, cancel all cycles, and they treated IVF as a non-essential services. They said suspend elective surgeries. And look at the update 10, which has come on 17th November. And I think by the fourth update, which came in June, they really said that testing for COVID may not be needed, because they realized that, perhaps the sperm and gametes are not affected. And I think as of the latest, they are doing fertility services, but they are not really asking patients to even be screened for COVID. So I think look at the difference in across continents, across countries, across societies, how they are taking it. And they're saying that there is a painful wait, which is associated with even third parties for gestation carriers. And they again have left the wisdom of the clinic and the society to, or the clinic or the clinician to take the judgment even on third party, reproduction. So look at it in the 10 updates, how they have moved. I just wanted to really bring, this was a brilliant paper, which I was reading last night, which has come from Scott Nelson and Lamaka, both Europeans. And they really said how the recommendations between Europe and America are different. While SRM testing for SARS is not part of the routine workup for infertility patient, ESHRE guidelines have made it really fundamental. But look at the fundamentalism of ESHRE. What is the basis of testing a couple is antibodies. And we know that antibodies are not diagnostic. We have understood that there will be somebody who will be in the acute phase, may not give you positive antibodies, and somebody beyond 35 days of infection may again not give you antibodies positive. So I think, again, we have to really understand, whereas ESHRE is dependent on serological testing, SRM doesn't even want, because they say there is insufficient information on recommending in their algorithm. So I think as in India, or a continent where we are still looking up to these societies for whatever publications come, what should we adapt? I think is a very, very big challenge. And I think that's what should throw open questions. And look at the way triaging is being done. And this is what was the latest from the October guidelines, where they look at triaging only on the basis of antibodies, IgG and IgM in ESHRE. So I think I just would say that the ESHRE has given something which is very brilliant, something to say where you stand based on where your current rate is. And if I look at Delhi, I think till last week we had more than 12 cases per 100,000. So that was the infectivity rate. So if we look at it, we fall in the critical range, at least as Delhi is concerned. I think for whichever city you are, perhaps this becomes a very good kind of a monitor to sort of put you. And if we look at it, I think we really have to understand that we have to follow strict guidelines, reduce clinic visits, again, testing, remote medical advice, teleconsult. Lab again says freeze all policies to be concerned. So I think, are we really in a position to make our guidelines or look up to them? I think these still would say good enough to say, yes, we are not really in a position to say fresh transfer. And perhaps we are waiting when we'll reach to somewhere where our minor cases are or minimal cases and say, yes, go ahead and do fresh transfers. This is the data which you look at for Delhi. And I think this is where we stand today. So the numbers are really, really huge. So I would just end here that whatever measures that we are doing, I think the priority being a non-essential service is patient safety. But I think the word non-essential doesn't really, really sound well for somebody who's at the brink of losing a fertility at 37, 38, or who is, I mean, I'm not talking of cancer survivors, but definitely who's got a poor reserve or who has pressing concerns of endometriosis damaging the ovaries. So I think you have to be more judicious. Very important, take the SOPs in place, have your consents very properly done. The consents are very well vetted by the group that we formalize, and they're really, really say, I would say, still useful today. I think as the SRM says, as ESHRE says, as reproductive medicine specialists, we have to update our knowledges, and I think cannot work as in our own cocoons and kind of on our own shells. We all have to get together. And I think this kind of a webinar is, many webinars will be useful. Discuss our problems, put in our data, talk about our troubleshooting, counsel our couples very, very clearly. And I think very important, which I think we really need to put in, and we have put it even in our guidelines, is the emotional trauma, which is humongous. I think we're just going to say, yes, we're taking restricted patients. What about the mental stress that is being faced by so many of our couples who will really not make it to IVF in the next 6 months or perhaps longer? And I would just end here that teamwork is going to be the key way to success, not just for a unit, but I think for our society and our faculty and our specialty and all. And I think as all specialists, we all should gather together and work in team. Thank you very much.
Thank you, ma'am, for this very much needed practical update. I think the questions from the audience can be taken by Dr. Sheetal and Dr. Prabjot. If Dr. Sheetal, are you there?
Yeah. Hi.
Yeah.
So the first question, hi Bharti ma'am. Bharti ma'am.
Hi, yes.
Yeah, so ma'am, as we all know, there are no long-term effects as of now. So ma'am, I just wanted to know that are we still practicing these separate cryo tanks for from the time these COVID times have started? Are we keeping the embryos and the semen in the separate tanks, or are we still keeping them in the same cryo tanks? What is the policy that you are following? I just wanted to know.
At Nova, we have a very strict SOPs all throughout the country, and there we have been following the separate tanks for these patients. What we are doing, initially we thought at the time of pickup we would be doing the COVID RT-PCR testing and then go ahead, but then we realized many of our donors got positive at the time. So we started in the initial first, as soon as patient enrolls, maybe the donor or normal patient, we start RT-PCR initially, and then in case if it is positive, we cancel right away over there the cycles. But in case if suppose you go ahead and you find that the husband comes positive, so the oocyte freezing comes, they will have a separate tank altogether. All patients, we are not unnecessarily freezing. Now we had a cryo backup system SOPs initially, but nowadays with this COVID we are not encouraging cryo backup for the more couples, so we are restricting that, and the complete separate tanks are there.
Okay, thank you. Yeah. So the next question is for Dr. Neena ma'am. Beautiful lecture, ma'am. Ma'am, I just wanted to know that a lot of parts of India are following this batching of IVF. So now because of COVID, this is a big problem. So ma'am, what do you think is the current scenario? Can we do this batching of IVF now?
I think, Sheetal, it's a very relevant point, because you know what, in our community, and this is something which you're not prepared.
Yes.
And batch IVF actually means that you're preparing yourself with a floating embryologist. That's
Yes.
exactly what an eye batch is. I think I would say an absolute no to somewhere where you have a floating guy. Suppose the embryologist turns COVID positive in this batch, what will you do? Because you know, in a batch IVF, you're really working on minuscule stuff. And here we are trying to advise people that you have extra stuff. See, if you look at the way we are working in any of these setups, if you're looking in the COVID pool, or we're looking at our labor wards or any place, let's learn from there, you know, because those are services which are running 24/7. They're running back to back. And we know out of that, we're just working with 1/3 staff. We're keeping the 1/3 staff at our backup, because we know still our residents and doctors, 1/3 are turning positive, and there's something inevitable. You just can't prevent it. So I think with this kind of understanding, batch IVF shouldn't be an absolute no-no at this present time. Because unless and until like you, I mean, I don't think it makes any sense in the ideology or whole purpose of what we are talking is that we're working a tightrope. So, you know, batch would be somebody where in a situation we are free, we have all the access, we have everything. Here we have limited access to everything, and the limited access is human resource. So batch would perhaps be an absolute
Plus,
no.
clubbing of so many patients is also a problem.
Yeah.
So do we have time, or we should close the session? Jyotsna?
Last question to both speakers. That suppose you are dealing with the PCOS patients, and previously first PCR that Dr. Bharti Dore Patil says something that we are entering COVID-19 PCR is negative, and we started. Now, at the time of trigger, before 2 days, if she's positive and husband is still negative, and what to do? What you can do? I want both opinion on that.
No, in this case scenario, we have to cancel the cycle very importantly. But as you said, PCO means she must have had at least many follicles, maybe 20 or 20. So simply stop the gonadotropin, continue, and diagonist don't give her trigger and monitor her. Then slowly it will get regress. Your E2 levels goes down, your follicle starts regressing, and follow it her up, and then explain her properly, and just simply cancel the cycle.
So,
That's
madam, suggestions cancel. Dr. Deena Malhotra, madam, what are your
I
suggestions?
would absolutely say cancel. I think I was talking to some people in Pune who are really had, they said we have seen, and even in Gujarat, they said, well, we went ahead and picked up because we knew that patient has spent a lot of money. That was the thought which a lot of clinicians shared, and there were a lot of, we were doing these webinars on opening and resuming, and this is what's said. I think I would go by Bharti because it's, you if you're really worried about OHSS or PCOS, I would, besides antagonist, even add letrozole, because letrozole will be the tablet which can continue for at least 10, 12 days, and will be my take. I know there is no recommendation, but from learning as we do patients on cancer, survivors, so give her antagonist shots, 3 days or 4 days are enough, but she can go on letrozole, which will not be spending, but definitely I would not risk her life and also the rights by taking and doing a pickup for her.
and we have a strict policy in Nova. Cancel means cancel the cycle. We are not picking up the eggs from these patients, and as Dr. Neena said, we are also adding the letrozole as there is no evidence, but still it definitely gives the E2 level very low and patients becomes very much better, and you don't have to worry about the patient, but just simply cancel. Don't tempt at all for the.
And one thing, I think, Jayesh, when you were to take this patient, you would have consented her very well, even if she has PCOS well ahead, that if she turns positive, so there should not be any medical legal issue also.
Yes,
On the
this
part
is
of
a
the
good message to all the paternity. Now, I request Yogita.
I want to add one more thing, Dr. Jayesh. The thing is, when we see that is a PCO patient and looking at the AMH and AFC, we have to be very gentle in our ovarian stimulation. Don't stimulate that patient very aggressively, because we are not sure what's going to happen later with the RT-PCR test. So if we are gentle with our stimulation for those patients, not aggressive, limit the dose of your stimulation, gonadotropins, then we are still safer. So we have to play safe in especially in PCOS patients.
It's a good message. Dr. Yogita, can I move ahead? If any question again there?
Sir, we don't have any more questions. We can move on to now, I think, the next session. So thank you, chairpersons, and thank you, speakers, for sharing your experiences and knowledge. Dr. Jyotsna, we can move on to the next session, please.
Yes, Yogita. After the wonderful session 1, let's move ahead with session 2. And for session 2, we have Dr. Shushma. Dr. Shushma is a senior consultant and an IVF and laparoscopic and robotic surgeon in Indraprastha Apollo Hospital. Our next chairperson is Dr. Ela Gupta. She's a director and senior consultant reproductive medicine at Ferticity Fertility Clinic. And she is a MS OBGY and diploma in IVF and reproductive medicine from Keele University. Our next chairperson is Dr. Beena Muktesh. She's a clinical director at Cloud9 Hospital, and she has a special interest in fertility and reproductive medicine, and she's a trainer also in the same. Our next chairperson is Dr. Sanjeev Khurd. Dr. Sanjeev Khurd is a consultant infertilologist and IVF specialist, and he's also past president of Pune OBGY Society in 2009 to 2010. Yeah. So I would like, I may request Dr. Ela Gupta to introduce our first speaker, Dr. Pranay Ghosh. Dr. Ela?
Dr. Pranay Ghosh, welcome you for this session and the talk. And he's the director of Elixir Fertility Center, Delhi, consultant at Double Helix Clinical Cytogenetics and Reproductive Immunological Center. So he'll be talking on the IVF lab issues during COVID-19. So we look for the embryologist perspective, what our embryologist has to say on it. Over to you, Dr. Pranay now.
Thank you so much. I'll start my screen sharing now. So I'm just going to present a practical point of how, as an embryologist, I look at the obstacles that we have seen in the past few months and how we are modifying our practices based on the upcoming recommendations, the revisions, and so on and so forth. And a lot of the introductory slides will be a repetition of what we have already covered in the first two lectures. And needless to say, I think regarding the COVID tally, the rising cases, we have probably all but given up counting the cases every day. And there have been a plethora of societies which have come up with their recommendations from as early as April. And we have touched upon most of these in the first two presentations, but I'll just briefly mention some of these. And as Dr. Malhotra already mentioned, ASHRAE came up with a few statements in which they mentioned that all the fertility patients should avoid getting pregnant and all ARD treatment should be suspended. And then there was there were some statements regarding phased resumptions of the ARD services. So as far as the situation in the lab is concerned, I'm sitting in the lab right now on a Sunday morning, but for a totally different reason. So this is considered as one of the safer locations in the healthcare facility because of its isolated nature, its air filtration, because we are working with a lot of air changes and we have modified our air filtration units to be providing a lot more replenished air rather than, a lot more fresh air as compared to the recycled air. So we are having a lot more fresh air changes in our lab following the pandemic. Then we are working with a screen population, a control patient population who per se are not sick, and they are low risk patients to start with. And then the specimens that we work with, the follicular fluid and the semen, are comparatively lower infectivity as compared to something like sputum or bronchial alveolar lavages. But there do exist some concerns regarding infectivity from whether it is between staff or patient to staff or vice versa, and even between sample to patient and from the clinicians and the embryologists to the samples. So when we talk about the infectivity concerns of the reproductive tissues, whether it is the semen or the follicular fluid or the endometrium, the data is evolving. We started with the belief that since the ACE requires since the COVID requires an ACE2 receptor for it to be getting entry into the host, and that there would be no reason for overexpression of ACE receptors in the reproductive tissues, it would have been comparatively safer for us to be working with the semen and follicular fluid. But now we are getting reports, whether it is with infected patients who have been infected or with patients who have passed away due to COVID. And when on autopsy specimens, we have found that there has been changes in the tests which are akin to otitis, or there is a lot of overlap between any other infective etiology. So now we know that there is expression of ACE2 receptor in reproductive tissues as well, albeit as to not to that great an extent as to what they would be in the gut mucosa, the pulmonary alveolar macrophage tissue. So I probably came across one paper that mentioned that all it takes is an expression of just 1% in all of the tissue for the COVID to be showing a infective propensity. So I believe the semen, the testicular tissue, especially the circulatory and the Leydig cells, they have a lot more overexpression of ACE2 receptors, and they are possibly a little more infective if we compare them to the tissues like tubal epithelium or the cervical or the endometrial epithelium. So despite the initial emerging reports that it was probably deemed to be deemed safer to be working with the vaginal fluid or the follicular fluid or the semen, we now know that it may not be so, and good laboratory practice and precautions have to be practiced. So we have looked at this in the previous presentation, that we had a joint statement by the 3 fertility societies, and they laid emphasis on how to resume practices, and the aim was measured resumption of care. But before that, I would want to make a statement regarding a prior state in which we had to prepare for the lockdown of our services. And for us to be shutting down our services for even a couple of months, which was the entirety of the April and the first half of May, our chief concern was, apart from counseling of patients, was to maintain the embryos that we had in our cryo storage, because all of us had faced this one-off scare that probably will not be able to get liquid nitrogen as freely accessible as it was in pre-COVID era. Probably as of now, we are back to the availability is the same as pre-COVID era, but there was a time when we were actually thinking of investing in liquid nitrogen generators. And now we have tie-ups with more than one vendor, and we keep on rotating a vendor so that we have good terms with them, so that in cases of emergency, we can fall back to more than one vendors for the supply of liquid nitrogen. So as far as the resumption of services was concerned, we had to modify more than one thing. So I'm highlighting 4 points that we had to rebuild, and this started with information and consents. Then when we started, we did not start with offering all our patients the ART services. We had to select some patients and prioritize all others, so that we were able to do justice to them in terms of their needs for ART services. Then all of our patients, and not only patients, even our staff required trial screening and testing. And then after all this, we resumed our treatment. And as of today, probably there's no exclusion to any of the patients who would walk in, barring their COVID positivity report. And we are offering treatment to all our patients. But the humongous task that faced us was a revision of our information that we were providing and the consents to our patients. And this was something that we did during the lockdown when we were not doing any treatments at all. And we had a couple of good resources during the months of April and May, and ESHRE, SRM, and even SAT. They mentioned a lot of apprehensions of patients, the questions that they were usually posing for their fertility clinicians and embryologists, with regards to the concerns regarding the safety of the gametes, the safety of commencing treatment, or the repercussions of delaying treatment, and so on and so forth. And with this and some sample modifications to the consent forms from others, we revised our information leaflets and consents. And following this, when we started in May, there were some patient subgroups that we were not refusing at all, whether it was COVID positive or not. And probably in hindsight, I would have done things differently. But with adequate PPE and other precautions, we certainly did not refuse any oncofertility patients and patients of diminished ovarian reserve or severe oligozoospermia or azoospermia. But as of now, sitting here in November, December, our patient selection is the same as pre-COVID era, and it's only the COVID positivity report or the screen triage positive patients that we are dealing for the moment. We have seen this with regards to the triage screening and testing. This has been put forth by the ESHRE, and we are only working with asymptomatic patients and which are triage negative. Our triage or our testing strategy is different than ESHRE recommended. They are recommending antibodies, as Dr. Malhotra said, but we are still recommending the RT-PCR for the nucleic acid. And any patient who shows symptom or is positive is of right refuse treatment, because we know that besides the patient being at risk, we don't know the repercussions of treating COVID positive patients. These are not necessarily sick patients, and their treatment can be delayed if they are not looking for oncofertility treatment. So with that, we had followed this particular guideline, and we are triaging the patients at the outset, at the start of the treatment. One particular difficulty that we faced at the day 2, day 3 was advising COVID testing to all, and there were a lot of patient dropouts when the patients got to know that they would be required to undergo COVID testing at least twice. And this is if we consider a fresh transfer, and if we are considering a freeze-all, they would probably have to be tested in the freeze-all cycle as well when they are starting progesterone. So it was not acceptable to all the patients, and we realized that even if the patients are COVID negative, RT-PCR negative on day 2, day 3, during the course of the next 10 days of stimulation, some of them did acquire some symptoms and they had to be retested. So we did modify our COVID testing strategy to just one instance, and that is at the time of trigger, or in a frozen embryo transfer at the time of commencement of the start of progesterone. We have had cycle cancellations, and we have at least 2 or 3 cycle cancellations, some as late as on the day of pickup, because we still are having a difficulty in having the COVID report on the very same day. But the patients know it's for them. They have been adequately counseled, and they know that this is a scenario that was foreseen, and it is unfortunate that the treatment cycle has to be abandoned. So with regards to our particular modifications inside the lab is that we have had to minimize the number of people who are coming inside the lab. If we're working with a senior and a junior embryologist, we are now taking turns, or even if it's not, if there isn't ample workload, we are wanting one person to stay at home and be healthy, so that in times of need, in times of dire emergency, the other person can take up. And we have had to escalate the responsibility which we have put up on the junior embryologists or the technicians. They have had to upgrade the skills to much more than what was desired out of them in pre-COVID days. So now all of our staff is well versed with how to refill cryo tanks. I think I re-emphasize cryo tanks because it's my nightmare. I can't imagine a cryo tank running out, even though our cryo tanks are on alarm systems, on app-based callback systems. Even then, I think losing thousands and thousands of embryos would be a nightmare. So all our staff, whether it is a housekeeping staff or pantry people, everybody is proficient now with checking and refilling of liquid nitrogen. Apart from that, we are recommending good laboratory practice and PPE to avoid exposure, and PPE need not necessarily be a head-to-toe PPE that we associate the term PPE with. It may be simple mask, and it may not even be an N95 mask. We, as an embryologist, I use only N95 mask when I have to step out of lab and counsel the patients. And this is something that we are also minimizing. We are minimizing the exposure of the in-laboratory staff to the patients. And it's only at the end of the day that we move out of our safe haven and go out of the territory of the laboratory. Then we are wanting to lay emphasis on optimization of workflow. This may encompass a lot of things, but what we are trying to do is we are trying to trim our workflow, and we are trying to make our practices lean. We are trying to do away with unnecessary visits, unnecessary observations. If a patient has ample number of embryos, they are adequately counseled that we'll just have a peek at the embryos on the morning of day 3. And if due to any unforeseen circumstances, we decide to prepone the transfer, they'll get to know that on the morning of day 3, and we'll do a schedule late afternoon or evening day 3 transfer. Otherwise, all our patients who are having adequate number of fertilized oocytes are scheduled for either a day 3 transfer or a freeze-all. If a patient has a lot of optimal, when I say a lot of, an optimal number of vitrified blastocysts on day 5, we're not unnecessarily vitrifying day 6 and day 7 blastocysts as we previously used to, because knowing the utilization rate of the previously frozen day 6, day 7 embryos and the risk-benefit analysis of coming to the center, doing an unnecessary vitrification of something that will not probably be used. We now know that if somebody makes 6 or 7 blastocysts on day 5, we are just not doing any day 6, day 7 unless it's a PGT case. With regards to off-site sample collection, we did recommend it to our patients, and we still try to counsel them, but then again, we have faced a lot of resistance. I mean, this is something practical. We try to mimic what was told to us from the previous prior recommendations, but some patients do create a lot of if you can say, chaos regarding the need for an offsite sample collection. And then what we have done is we have dedicated them to a whole different area of the center. And we have 2 semen collection rooms now, one for the walk-in patients and one for the patients who have been tested COVID negative, either for IUI or IVF, and it's for the use. Then we were a clinic which, to start with, did not have any paid partners either for the pickup or the transfer, but clinics, especially in the West, who do encourage partners in the OT or the ED suite at the time of the procedure, are now not recommending that anymore. Emphasis is being laid on disinfection of consumables and media because of the survival of the COVID on the cardboard and the other thermocol boxes from as short as 8 hours to as long as 3 to 5 days. This is now being recommended. There are a lot of agents, and we'll briefly touch upon some of them. And as I mentioned, the staff may require retraining, especially trainee embryologists, because now we desire more out of them. And then to start with, when we are restarting our treatment, there was a talk of shifting to closed system of verification. But now, with all the information, especially from our fellow colleagues across the world on platforms like I3 Initiative, we now know that more than 75% of the embryologists haven't changed the way they did their verifications or even dedicated a specific cryocan, even though it's recommended. And they are continuing working the same way with regards to verification as they used to in the pre-COVID era. Equipment revalidation. So if you are one of the clinics that shut down their equipment during the months of April, May, or June, and they are now looking at restarting their equipment, it is desirable that the equipment be revalidated. We did not shut down any of our incubators, so we are good to go, but it would be it would be advisable that if you were starting your incubators after a gap of 2 to 3 months, you get them recalibrated. This is a crowded slide which showed that what is the particular PPE which was recommended for a particular ART procedure. And this is taken from the SRM recommendations, the one that Dr. Malhotra has been mentioning, that has undergone a lot of revisions, as many as 9 to 10 revisions. And we now know that it is only the aerosol generating procedures like pickups or operative hysteroscopy or laparoscopy, in which the patient has to be intubated, which generate a lot of aerosols, that maybe you're better off donning a whole PPE or at least using an N95. But for our in-lab procedures, we are now doing with a surgical mask, and we don't use N95. So when we talk about cryocans, a cryo repository, I feel that some people have taken the opportunity of COVID as propagating their own stuff or their own propaganda, like liquid nitrogen sterilization or witnessing systems, closed systems of vitrification. But essentially, we haven't changed anything. If we look to the pre-COVID days, we had a specific dedicated cryocan to start with in the months of May, but now we are not we are not recommending a specific isolated cryocan for our post-COVID resumption cases. So we straight off refuse patients who are COVID positive, because just like viral positive patients, HIV positive or hepatitis B positive patients who require a dedicated IVF lab, to be honest, and who we recommended being rerouted to tertiary care hospitals where these facilities were available. Even COVID positive patients who are wanting IVF treatment are without any further delay are being rerouted treatment facilities where they will be catered to. As I mentioned, there has been a lot of talk about a closed system of vitrification, but I really haven't come across anybody, and in a survey of a lot of embryologists across the world, only 20% of them mentioned that they have shifted on from open to closed system, and only for their embryos, not even for oocytes, because they're still sticking to open system for oocytes. Then it can be said that vapor phase storage can be considered for cryopreservation, but again, it is not recommended because of the high risk of thermal damage. And if you look at, again, risk benefit analysis, it won't be a suitable option. Separate trial containers, I've talked about that, but if you're considering one, you should also consider and factor in the additional cost, space, and time required to monitor it, and along with the need for an additional alarm system. So these are a couple of slides that I've taken in from the document that came across from the IFS-SR ACE regarding the resumption of services. And it does mention a lot of good points. I'll just try to go through them briefly. So we have a deep cleaning of laboratory at the bigger, especially when we started, but in our day-to-day practice, we do cleaning with quaternary ammonium compounds. And in between cases, we allocate a lot of time between two pickups to clean our laboratory. And I always tell my fellow colleagues that treat the level of your cleanliness as akin to what you would be cleaning the lab when you would be performing a PGT. So if you're satisfied with your pre-COVID PGT cleanliness levels, I think that should suffice. So we have mentioned that we are working in a safe environment, and it would be very unfortunate if the one-off contamination would occur, but still our lab is considered to be one of those safe locations. We should be following good laboratory practices anyways, whether it was COVID or not. And this is a reminder for anybody who's using mouth pipetting to just give that archetypical practice right now. I mean, I know it is easy to use, but this is the right time to be shifting on to hand pipetting. Use PPE. We've talked about the level of PPE required for different procedures. And if you have adequate staff, try to arrange for two teams. Somebody would do the morning shift and somebody would come in for the evening shift. So somebody who can do all the pickups and embryo transfers and leave the vitrifications and biopsies for later on to be done by the second team. And when you're working in teams, just be mindful that working with good laboratory practice within the lab doesn't matter at all if you are going out and venturing into things that are going to be harmful for your patients. You have a responsibility towards your patients and their embryos. So restrict your social life. Don't go berserk. Don't go wild, partying and socializing. These things can wait. So train everybody, train the interim staff to refill crowd tanks, because again, this is the one thing that can prove a nightmare. A lot of emphasis is being paid on the electronic witnessing systems, and if the clinic can afford that, it is very easy to incorporate into your system, and it does do with a lot of physical witnessing. If you cannot afford that, you can do a telematic, telephonic, or a FaceTime witnessing as well. We are trying to minimize the avoid the practice of counseling by the embryologist to the patients, and if at all we have to do that, and we do have to do that a lot of times, especially with regards to the PGD patients, we use telecommunication services. But make sure that the communication is not hampered, because it has to be crystal clear. Some patients would change their mind at the very last day, on the day of biopsy, and you have to be very sure about what the patient's desire out of you, and there should be no scope for communication errors. Use dilution for discarding follicular fluid or semen samples, and this should the dilution method should to a great extent negate the effect of virus, if any. Clean the shipments that you are receiving, especially the media and the disposables. UVC has been recommended by some for disinfection, but we usually don't recommend it, because it does have some irritant and harmful effect to the mucosa, skin, as eyes and skin. And I think the other cleaning agents like the quaternary ammonium compounds or hydrogen peroxide or hydroxychloric HOCl can do away with the need for UVC. With regards to semen testing and processing, we are not testing each and every patient that comes in for a walk-in semen analysis, but we do now handle our specimens a lot more diligently and carefully. And we use sterile hoods for semen testing and processing, and especially if you process the semen sample and you open your test tube, that is a moment when there would be a lot of aerosol generation and escape. So do that under your sterile hoods, if possible under type 2 hoods. I know not a lot of Indian clinics would be having type 2 hood, but try and use if you have one. And clean all the laboratory surfaces and collection rooms with embryo safe material, but don't use anything that generates a lot of VOC. We've talked about offsite sample collection, and we still recommend it, given that it arrives within an hour, but it may not be possible for all the patients. You have to gauge each patient's his mentality, if I can use that word, and try to use sperm counting chambers which are disposable. Again, this may not be possible because of its cost prohibitive nature, but try to use and disinfect the chambers after each and every semen analysis. So this is last 1 minute that I have, probably. Yeah, there are a lot of agents on, in the market regarding the ones that can be used in an embryo safe manner. And again, just a caution, don't use alcohol, generates a lot of VOCs. There are a lot of alternatives, quaternary ammonium compounds, hydrogen peroxides in concentration of 3 to 6%. And with that, be mindful of the contact period that these agents would be required for, because if you just use safe or 40 safe and just wipe it off, I think it's not going to serve the purpose. So with that, to summarize, I think we have had a lot of information regarding the phase service, resumption of services, and most of us have started with our services. And I think with a lot of precautions, we are back to pre-COVID era with regards to our workload, but with a lot more precautions at hand. We have to physically distance us with the patients and sample, with our colleagues, not only in space, but also in time. Use appropriate PPE, which is specifically designated for each and every ART procedure. Triage your patients and personnel and use telehealth. This is a indispensable tool at your hand right now. Ensure adequate staffing, because there would be times when you would have one of the staff coming in contact with patient who would come out positive a couple of days after, and then there would be quarantining required for more than one staff members. You have to be very diligent about your SOPs, and all your policies have to be now specific to COVID. And I think with good patient information, resources and leaflets and counseling, this is a time period that we can tide over with precautions. And I think we are trying to do our best, but these are some guidelines and some recommendations that we should be following, so that in this time of uncertainty and especially medical legal litigations, we can be safe and say that we have worked with the maximum information and recommendation that we had up at our hand at that point of time. So with that, I would like to end my presentation, and thank you.
Thank you, Dr. Pranay, for the elaborated session regarding the lab issues and all. Now, I would request Dr. Sanjeev Khurd to introduce our next speaker, Dr. Poonam Nair.
Hello. Good morning. It's a pleasure to introduce Dr. Poonam Nair. She's a doctorate in clinical psychology and clinical psychologist at the Akanksha IVF Center, Mata Charan Devi Hospital, New Delhi. She's into teaching and research for the last 15 years in integration of mind-body methods with existing standardized treatments for stress management in psychiatric disorders and IVF treatments. She has had 25 publications in various national and international journals. She has conducted workshops, presented papers at IFS, ESHRE, ASRM conferences on stress, infertility, and counseling. She is member of ESHRE, life member of IFS, Behavioral Medicine Society, and Scientific Research Committee for International Journal of Yoga. So I give you Dr. Poonam Nair.
Poonam, ma'am, are you there?
I asked Dr. Poonam to start a talk. Yeah.
Good morning, everybody. We are going to talk about psychological stress of the COVID patient. And when there's infertility, and on top of that, we have got the COVID problem. So what happens to this person, how he reacts, and what we can do to help. So I found some data on it, which I'll share with you. and we will try to integrate it with the theories of stress so that something practical we can get out of it. शेयर स्क्रीन में केली शेयर स्क्रीन आ गई ना इधर रखो I'll just put in my PPT. Okay. I'm just loading my PPT. Just give me a minute, please. Okay, it should be here.
Please share your PPT, ma'am.
Yeah. नहीं खोली नहीं हुई बट खोलेगी तो भी शेयर करेगी नहीं डेस्कटॉप से लोड होती है नहीं ओके just
Please change the tab.
I have to open it first.
Yes, please change the tab.
It's on my desktop. Okay, just give me desktop पे खुली तो नहीं होती है कभी भी मिनिमाइज करके
Ma'am, please change the tab. You are on the Google tab. Go on desktop and please share your PPT, ma'am.
Okay. तो ये तो मेरी अपनी डेस्कटॉप पे हो रही है अब लिंक कहाँ है इसका
लिंक नीचे है ना हेलो वही कर रहा हूँ बेटे वो लिंक खोलेगी तो एक लिंक खुला हुआ कहाँ है
खुला हुआ था उसी शेयर लिंक से ही आता है कि तुमने
यार देखो जो मैं बोल रहा हूँ ना
ओके आई ओपन इट
हाँ नेक्स्ट स्पीकर ले ले बेटे
unnecessary okay just Zoom meeting में share link
Can you just mail your PPT to one of the mail ID I'm just sending to you?
Yeah, it's already sent with it's already with Atul. It's already been sent. Not Atul. Yeah. Shivam.
Can we take question answers meanwhile?
Can we meanwhile take
Dr. Bina, I suggest we can take the questions, one or two questions meanwhile till we can share the slides. We have questions in our chat box.
Yes.
Yeah.
One of the questions which we have is actually we are just thinking everything from the patients and the staff's perspective. We have had all the staff perspective and the infection for the patient, the baby, the staffs. That the question now is from the patient's perspective also we have to think. They have a question which they always ask. We are coming to your center and what about the staffs? Have they been tested? So this is one of the questions which comes to my mind also, and there's a question there on the chat. So please answer that question. Hello? Hello? Am I audible? Hello?
Yes,
ma'am. You are audible.
So yes, I'm talking from the patient's perspective. They have the questions that are the staffs here tested? What about us? This question is from Dr. Pranay Ghosh.
Okay. Yes, ma'am. We had taken this opportunity to get the antibody levels tested for all of our staffs, but only on one occasions. And after that, our staff is tested only if they become symptomatic or if they have traveled, because a couple of our staffs had to travel due to some unforeseen circumstances to their native cities, and they were quarantined there on a couple of occasions during entry and during re-entry into Delhi, and then retested prior to being allowed to resume work at our center. Over and above that, the clinicians and embryologists are only tested when they are either symptomatic, or we don't offer testing if they come in contact with a COVID positive patient, a patient who has symptoms but did come out COVID positive after being prescribed a test on a couple of days after being seen. So on that occasion, we have had to quarantine ourselves, and we have had to have the backup physicians and the embryologists come in.
Uh, what about if you have done the embryo transfer the day and the same day you test positive? Then
we won't do there is no way that embryo transfer would be done without a fresh RT-PCR report. And I think if the patient is RT-PCR negative,
no, that is for the patient. I'm talking about the doctor. The doctor who did the embryo transfer, and the same day she got herself tested, not because of the symptoms, just like that, and then she came out positive.
This is a fictitious scenario. We won't be testing unless we were symptomatic, and if we were symptomatic, we would test ourselves, wait for the report, and then do the transfer, or else ask one of our colleagues to help us in this circumstance. We would not jeopardize the patient's health with a pending RT-PCR report, either of the clinician or the embryologist. We understand the.
So the bottom line is that even if you all of the patient and everybody is negative, you should always use the PPE, you should always use the visor, you should always the face mask, double face mask and everything. So take the precaution, because you never know, asymptomatic patients can be there amongst yourselves, amongst your staffs and the doctors, and among the patients attendants also. So everything is possible.
Now we can see Dr. Poonam Nair's slide.
Yeah.
So let's start with the lecture first, and then at the end we can take rest of the questions.
Sure.
Yeah, Dr. Poonam, over to you. Poonam ma'am, are you there?
Yes, I'm there.
Over to you, ma'am. Yeah.
Okay. Can you hear me now?
Yeah, ma'am. Yeah.
Okay.
Do ma'am, slideshow, ma'am.
Yes. Yeah, that's what I'm doing. Okay. Here we are trying to balance COVID precautions over fertility treatment, because the infertile patient is already under a lot of stress. There is a sense of urgency, and there is uh, he's already in anxiety and depression. So on top of that, when you put a demand of when he's under the pressure for COVID and all the restrictions and all the problems which come with it, so what to do with such a patient, how to convince him or her that to balance out, to wait, because we are all in a very unpredictable situation. So there has been an increase in stress world over, and everybody knows there's more anxiety and depression than historical norms at this point in time. There's rampant news about increase in domestic violence, child abuse, divorce, suicide rate. In fact, they're saying the next pandemic is going to be one of mental illness. And this is, people worry about becoming mentally unwell due to uncertainty and loss of control. So what is the effect on infertility treatment when there are millions of cycles of fertility treatment, and there is a major disruption in the treatment plan and progress? Some centers had to be closed, like our reproductive biology center in LNJP. The entire hospital was converted into a COVID hospital, and it still hasn't resumed. So the effect is that although they are reopening, but still much uncertainty remains for patients about how they will resume. And there's always a threat of second wave of COVID-19 and a closure associated with that. A vaccine is not expected for some time, though some are promising. Now, patients, how do the patients understand the disruption of infertility treatment? How do they conceptualize it? This is based on surveys, and it is found that they perceive that the reason why infertility treatment is stopped because of the general scenario for the safety of healthcare staff and general population, reduced strain on healthcare services and so on, and all the logistic problems. But personally, they feel there is no benefit for us in this entire thing. In fact, patients, although they partly understand that the treatment is disrupted because COVID effects are still being studied, the effect on pregnancy and childbirth are unknown. But they still ask that if fertile people can have children in COVID time, why can't we? And closure is seen as unfair and discriminatory, and they are distressed, anxious, and depressed. So, if you want to understand how they are reacting to COVID and their infertility problems combined, if we can look at the stress process, the stress process is a combination of various factors operating together in synergy. And although for academic purpose we have separated it out, but it's all actually very interlinked. First is the stressor, which is the COVID situation, and that then the resources which a person has, physical resources like money, like food security, personal resources like life skills, communication skills, education, and so on, social skills like how much social network he has, how many people are ready to help him. So the stressors, the sources, and they combine with the personal characteristics of a person. There are physiological characteristics. There are people who are biologically unstable and prone to stress and mental illness. There are psychological temperaments which are very innate. And then there are cultural factors. So when all these three dimensions interact, the person has what is called a stress appraisal. That is, after he assesses the stress, there is a stress appraisal, there is a, a response to the situation. So what we are seeing in the COVID patient is an outcome of these four dimensions which are combining in a synergistic manner. And so here the stress appraisal, the stressor, its complexity, intensity, and duration, and frequency. So here the stressor is obviously very complex, and duration is, it's become like chronic. It's not a one-time hit, and it's not like come and go. So it is something which is lingering on, and the intensity is very high. The resources are like how much, there are people who are very badly affected, who have been thrown, their life, their businesses have closed down and so on. And so these resources are there, which are again individually variable. Then personal characteristics like health, resilience, optimistic outlook, high intelligence. So when all these combine, we have two levels of stress appraisal, what is called a primary appraisal, which is a automatic instantaneous reaction that, oh my God, this is something awful. There is a big threat around the corner. So once that there is that immediate, it is a like fight and flight kind of a instantaneous reaction. After that, there is what is called a secondary appraisal, in which the person at some level sits down and partly unconscious, partly consciously evaluates the coping. What can I do here? What are my resources? Can I really withstand this problem or not? Will I be able to get on in life? And so on. So when no coping possibility is perceived, then we have what is called a distress or a negative stress syndrome. And we all know the sequence of that, the alarm phase, the resistance phase, and all those things, they can, how they will activate, you know, that is a very big story in itself. Then if coping possibility is perceived, then they take on the challenge and they try to get on in life. So our attempt is that from all these variables which are there in a person, there are some which are under our control, which we can manipulate, and there are others which are totally out of everybody's control. So in this, if we understand, I think we can help the patient with more clarity. So this I have already said. So this is the data on primary appraisal that almost everybody appraised it as a threat. All the infertility patients whose treatment got disrupted, they appraised it as a threat to the attainability of the parenthood goal, loss of the family dream. So this was a big shattering. And then this is again a combined outcome of not only the event, the uncertainty about the COVID and its effect on treatment, poor ovarian reserves, poor egg quality, and what is going to happen if we delay for 6 months, maybe even longer, and so on. So this delayed fertility treatment, how it is going to affect me, that is a big doubt in the person's mind. Then already they are having other life stresses. There's already a pre-existing infertility problem, like history of unsuccessful treatment, miscarriage, long waiting period for treatment opportunity, and so on. So, and then there is a personal pre-existing characteristic of pessimism, which has combined to give this primary appraisal of threat. Now, interestingly enough, in the survey, it was found that when we interviewed the patients, they said, yeah, the situation is very bad, but I can manage. This is the response of almost 90% patients. There are about 11.8% who had a complete breakdown, that is with psychological response, physiological response, suicidal ideations, and the entire gamut of disbalance. But let's see what these people who were in the 88%, what they actually did. Were they really able to cope? Uh, so what they did try a lot actually. So they were trying to access what is called tangible resources. They were trying to get information. They were trying to access the clinic staff and get to know more so that they know what's going on. Then, although again personality they were trying, but overall the view was a pessimistic one. Then they were trying on their own intuitively these three types of strategies, which is called thought management. Then there were a very few who were trying to get mentally and physically strong for a next treatment, and they were trying to keep up to date with latest information. So they were trying these coping mechanisms, and they were trying to strengthen social network with others in similar situations and improving relation with partner and so on. Now, the thought management strategies which they were trying is this is to cope with uncertainty and waiting. Now, here the situation is uh, is not something you can do much about. If there's COVID, it's there. You can only change your behavior or change your mindset or change your emotions and try and protect yourself in the best possible way. So what they were trying is trying to keep busy, distracting, which is called distraction coping, doing this and that. Then trying to focus on the present through yoga, meditation, mindfulness. Then there was this positive reappraisal that, okay, trying to find good in small things in life. Okay, at least I'm alive, at least I have food, I have shelter, trying to see something positive. Then comparing themselves to others that, okay, at least I haven't fallen sick. And they were just somehow trying uh, to have a positive appraisal. Then there was another group that is thought avoidance. I don't want to think about this at all. I can't control it, so why bother think? Then there's a denial that, okay, anyway, it will be over 1-2 months, so it is meaningless. Then there were people who turned to professional counseling. Now, this seemed like a good thing that some were getting ready this was a very healthy response to, they were exercising, having healthy diet, managing weight, taking vitamins, and they were giving body rest for the past burden of treatment. But there were also some who completely slipped up, using bad habits, drinking, eating rubbish, and not exercising, not being able to sleep, and all those things. So there were some who were strengthening social support network by staying and communicating with their partner, reaching out, maintaining contact, use of social media for support like WhatsApp. But for some, this was also a place to express their frustration and anger, that they felt that why, normal people can have children and there's no risk to them, why risk to me? But not all social contact was positive, because on the internet they started disconnecting with women who have children, and they started blocking them also. Now another information gathering was another very positive process which they were trying. Now here, despite all this, the scoping was still not optimized, and of course 11% were totally they were had a breakdown. And this is the, despite all this effort, this 80-90% who said I can manage, actually this was their emotional state. This is, you look, all the negative emotions were significantly higher than the positive ones. So although intuitively they were using some mechanisms, that is not enough. Then the cognitive appraisal. Look at the negative. They felt this is negative, it is very stressful. Only few, the people who said I can cope, it's controllable, or it's positive. So even in that 89%, that overall the average uh, intensity of this confidence that I can cope was quite less. So they were trying, they were struggling to manage. So how can we optimize this? What is suggested is this accommodative strategies, which are good when people modify their view of the situation rather than try to change the situation, which you just cannot change. For example, they were using these distraction, acceptance, and a reappraisal are best suited for uncontrollable situations. But however, because the benefits are not maximized because of significant stress reactions, so there is a need to boost and to give them these strategies in a more structured way, so that they use them consciously, deliberately, and they can really make better use of them. Then information resources was also a bit mixed up here. uh, they what they have, there's so much rumors about what's right, what's wrong, eat this, eat that, try this, there's so much hodgepodge of information about everything. So a very important thing is that we should have uh, to make that a proper coping mechanism. Having good information is a very powerful tool. Having that helps to control the feeling of uncertainty. So what is suggested is that we have a centralized resource in a single web page, and keep consistency between contents here and those delivered via social media. So in this, actively monitor misinformation circulating about COVID-19 effects, and to counteract it with the patients. Now here, keep updating, because every time some new information is coming. And then if there is a website or some media to communicate with the patients, indicate that okay, this website is going to get updated every 1 week. If there is a change, if there is no change in this information, we will acknowledge that there is no further developments here, so that the patient also realizes that the information is getting updated. There is uncertainty for the doctor and for the patient, and we are just trying to move in the best possible way. So at least for that time, they are able to leave the uncertainty. Then there has to be a mechanism by which the patient can also voice their concerns. and this can change as the situation changes. And these can be addressed in information updates, whatever queries they have or questions they have, so that the clinics can identify and address the common patient worries. Then the patients must have regular information on uh, about reopening and when it is going to start operating, and the clinic also must meet stringent criteria for operating, for taking on increased load because of the health and safety concerns. So that the patient is very clear why there is a delay, why there is a disruption, and it is also a health and safety concern for the patient, which is important as much as for the public or for the doctor and the staff. And then here we give them access to treatment, where we tell them in a very transparent manner about waiting list, about who are going to be prioritized, what will be the change in working practice, what will be the work hours, staffing, all these factors are going to change. So when the patient knows from authentic source, then they are also prepared in advance to manage their expectations. They don't have unrealistic expectations. Here again, health and safety information, so that once they know where they are going, even in this uncertain storm, where they know that they are being guided by the right knowledge in a truthful manner, that would help them a lot to lessen their anxiety and other emotional distress. So we have to provide trustworthy information source about effect of COVID-19 on fertility, pregnancy, and baby health, to help patients keep up to date, reassure patients about medical issues like safety of stored gametes and embryos, effect of delay on pregnancy and success rate. And here keep in mind that there are groups which may have special needs, like people who have come from far away, cross-border patients are there. Then there are third-party reproduction cases where they will require further additional support and clarification. Then here patients should know how fertility care is constrained by COVID-19 operational requirements. That there is a warning for the patient that new knowledge takes time, and we all have to tolerate periods of no change status in clinical updates. And information providers can ease this waiting if dates for regular updates are clearly indicated and no change status is explicitly acknowledged. Even when information is provided, it is important to tell the patients that it is subject to review because of constant emergence of new evidence and a rapidly evolving situation. And sometimes when the patients say that this is unfair, this is not good for me, so there should be a logical explanation to this, that the fertility staff is responsible for the welfare of the child. They are also party to bringing in, they are part of their parent project, and so they are bound by duty of care, which is not imposed on couples achieving pregnancy without treatment. And however, these constraints like closure, like delay, are applied for shortest period of time possible for the welfare of all. So finally, patients often want personalized information and not just information. And this is a challenge for everybody, because this, this, whether how much that is possible. But in this, uh, for example, if most patients are worried about effects of delay on, so for some people it may not make a difference of 6 months, but for others it may clinically actually make a difference. So somewhere the information has to be as per the patient medical status also. Now, Another thing is to help these patients connect with other support groups and with counseling organizations which are very strong now. There are a lot of voluntary organizations who offer free online counseling to all groups of people. So thank you.
Thank you, ma'am. It was a very informative session. And now I would like Dr. Shushma Sinha and Dr. Beena Muktesh to take over the charge for the question and answer session. As I'm seeing that a lot of queries are there in the chat box. So, ma'am, over to you, Dr. Shushma and Dr. Beena.
Yeah. There is one question from the audience. Should we postpone IVF in patients on antidepressants in the COVID-19 infection era?
Poona, ma'am.
Yeah, and see, antidepressants is how it interacts with the fertility medication, that is purely physiological medical science. But surely if a person is so depressed to be on medication, then it is always, you know, already that means they are very vulnerable. Their, their resources are weak, their coping skills are already collapsed if they are going into depression which requires medication, because mostly milder form of depression is not even given medication. They are just treated with CBT or something like that, and it works very, very well. So if they have gone to that level, that means there is already too much vulnerability in this person, and an added stress of COVID plus depression. Yes, I think this person should get first settled with the help of a mental health professional, and then once he's stable, uh, you know, the treatment can continue.
Dr. Sanjeev Khurd has asked one question that is not related to this psychology, because we have had this psychologist perspective as well as this embryologist perspective. So he has asked one question: after how long should we start ART treatment for patients who have recovered from COVID-19? This question is from Dr. Pranay.
I think you know, this is a biology question. So
Yeah, not from you, from Dr. Pranay.
It's a biology question. Yeah.
Yeah. So had in the past 3 or 4 months, we have had close to 7 or 8 cancellations. This is a mixed bag between the pickups and the patients destined for frozen embryo transfers. Amongst all of these, only one patient has come back expressing the desire that now that she is symptom free and a repeat RT-PCR is negative, and that she is having antibodies and would want to proceed with the treatment, because as such she was poor responder and did not want to jeopardize her future attempts because of the time. So we have commenced on a treatment plan after the initial cancellation in as early as 3 months, and the patient was symptom free, symptom asymptomatic, and RT-PCR was negative. So it was reason enough for us to get back on the treatment plan, especially for a poor responder.
For me, I think I had a patient who was positive with RT-PCR just before starting the frozen embryo transfer. We were just going to start her for down regulation, and then she came out positive. So it was postponed. And after 15-20 days, when she became negative, she just contacted to and expressed her desire to go for the frozen embryo transfer in the next cycle. So I went ahead. I did it because she was negative. She had antibody present. So I went. I don't think there is any need. I will ask all of you. There is any need to postpone it for 3 months or 6 months like that. You can do once she is negative, because you are doing all the treatment, including doing all the surgery and everything. When the patient becomes negative, RT-PCR negative, and she has antibody in her, then you go ahead and do it. So why in IVF we should be postponing it for 3 months? Can you explain, please?
I would like
3 months
to add
was for this
something.
particular patient, but yes, point well accepted that as long as the patient
Hello, yeah.
Hello, we can't hear. Yeah.
I think so, Dr. Pranay Ghosh video, and I think so we can lose his communication.
Yeah.
But the thing is that yes, embryo transfers, you can proceed, madam, because embryo transfer and asymptomatic patient, that's fine. But the thing is that the couple, those who are having a positive, especially male positive, there is do effect if they have still pickup is remaining. So you need to recheck the conditions. And another second thing is general condition of the patient. Patient, those who are very serious, gone through the certain disease, they should have to give a time, because you can see something, you can have experience that those who are having a even positive, there are certain group of the patient now, they are having different symptoms, more weakness, the general conditions I'm saying that. So they are not able and cope up the conditions. So it is all about the patients and doctor decisions, seeing the general condition of the patients and everything.
That is only when the patient had COVID infection and she
Yes,
was
yes.
sick. If the patient, because you are doing it routinely and the patient is not sick, you are doing it routinely, asymptomatic patient comes out to be positive. In that case, I'm talking about. If the patient is sick, of course you would postpone it, no doubt.
Yes, yes. But asymptomatic patients and freeze embryo transfer, again, I would like to report that why even that something like that, you can transfer the embryos and go ahead also. It is all what you can do. But asymptomatic and FET might you cannot do, offer the test also in freeze embryo transfer in patient, because what is your experience of 500 patients? If you have recruited your 500 patients in last 6 months, then what is your experience that asymptomatic patients do have a COVID positive?
Yeah, it's quite often it comes out, even with IVF, with surgery, pre-surgery also, patient comes, is there and she's okay, asymptomatic, and you do the COVID test and it comes out to be positive. So it happens.
So I have I have a last, we started in May 25, and this is now December is going on. We completed already more than 400 cases of IVF. And our experience is only 3 cases, because my strict criteria to go enter with the COVID-19 PCR test, and we are doing all this strictly. But still, I want to say my sharing experience that only 3 patients out of them, all are asymptomatic, right? Out of 3 patients only, they have detected as a COVID positive. And only, even though Ahmedabad, you know, that's a huge pandemic here, so you can understand what is the level of infected patients, and only 2 donor cycles do have a positive COVID positive. This is my experience I am sharing, and putting all together what we are just for the future, because if this going on, then what we have to do, that is all depending on our consultant, that doing a test to asymptomatic patient for the future. At present, yes, I am following strict criteria. But for what will be the future to go ahead for this all test of PCR in asymptomatic patients? Because incidence is very low. And even the false positive, lastly, one patient is CT value is 24. Patient came from Pune for treatment here. And for one cycle is failed there. And for second day of the stimulation, because we sent on the first day, so I said it's asymptomatic. So second day it comes to positive, and CT value is 24 in one lab. And government has given lot of lab now to go and do the PCR test, right? And then we investigate in other lab, it is negative. Now after 6 days, again I repeated, it is negative. So this is what I want to say, that you have to repeat the test also when patient is asymptomatic.
Any more questions? I don't see any other question on the chat box, or yeah.
Dr. Poonam, is there any statistic showing that how many of the waiting patients getting treatment for infertility and IVF. In the COVID times, they got pregnant naturally while they were waiting for any kind of active infertility treatment or IVF. Do we have any statistics for that? No.
No, I haven't really. I haven't searched for it actually.
Okay.
Thanks.
I have to say one thing, Dr. Poonam just spoke about. We can delay for 6 months. It's not a big thing to delay for 6 months. Yeah, even we won't, differ from delaying it for 6 months if the patient is willing. But if the patient is old, her AMH level is low, even delaying for 6 months is not going to be it's not going to be helpful, because we don't know about COVID, how long it's going to go. So it may go for 2 years, 3 years. In that situation, we can't give a time limit that yes, we can defer it or delay it for so many months, and then after that we will do, and it will be all right, because it's such a thing, we don't know anything about how long it's going to go.
The keeping the patient up to dated with whatever best knowledge we have, evidence based, and we are also working within our human limits. So if they know that we are sharing and we are moving with them, I think they will be somewhat calmed down by that.
Can I? Yeah. Yeah. Okay. I was just thinking, this discussion which had been going on, we all do not know much about COVID. We are still learning, all of us.
Yeah.
What the long-term outcomes, the short-term outcomes, we really don't know. Things will evolve. But I think what is important is thorough counseling and the limitations of how much we know and how much the literature tells us.
Yeah.
And we don't know what the long-term effects are, because tomorrow they might say, and it has to be documented. The counseling must be documented, and the onus should actually be on the patient to come to a decision.
Yes.
The moment
Exactly.
you make a decision for them that whether your AMH is low, your fertility, they can balance for themselves. Most of them are quite educated.
Yeah.
Understand probably, and then we can wait a while, maybe do over retrieval. We don't know what COVID is going to do to the ovaries and to the ova. That also will come in the distant future.
Yeah.
So I think counseling and documentation of that counseling, and a decision which is more from the patient rather than from us giving a decision to them, okay, now we will do this, or now we
Right.
will do this. I
Yeah.
think that might go a long way.
Yes, definitely. I think that's a very valid and a very good point. I think that's important also. That's really important. Yeah.
Yes, Yogita, you can start now.
Yeah.
Next session. Yeah.
Yeah, but I would like to request speakers to just stick to the timings so that we can just make it smooth further. Over to Yogita for the session 3. Yeah.
Thank you.
Yeah, for the next session, I would like to invite the chairpersons, Dr. S.N. Basu.
Yes, I'm here.
Madam is Senior Director and Head Department of OBGYN and Infertility, Max Super Speciality Hospital, Shalimar Bagh, Delhi. Dr. Parsuram Gopinath, Sir is Medical and Scientific Director, Simar Fertility Centers at Kochi and Coimbatore. Dr. Sonu Balhara, she is Head Reproductive Medicine at Artemis Hospital, Gurugram. And Dr. Namita Kotia, she is Director, Astha Fertility Care, IVF Specialist and OBGYN at Heart and General Hospital, Jaipur. Now, may I now request Dr. S.N. Basu to introduce our worthy speaker, Dr. Sohani Verma.
Dr. Sohani Verma. Am I muted? It's my proud privilege to introduce Dr. Sohani Verma, whom we have known for a long, long time. And she's such a conscientious, serious, hardworking person with so many accolades to her. She's a senior consultant obstetrician, gynecologist, and IVF specialist at Indraprasth Apollo Hospital. And she's been the president of the Indian Fertility Society, the chairperson of the North Zone AICC RCOG, and the joint organizing secretary of IFFS World Congress 2016. She's also the chairperson of the Free Communication Committee and core committee of RCOG World Congress, which was held in 2014. She has many awards to her credit. President of India Silver Medal for Academic Achievement, final year MBBS, Best Presentation amongst all lectures in fertility and IART at the 2010 National Conference AICC RCOG, Lifetime Achievement Award. You look pretty young to already have a Lifetime Achievement Award, but then congratulations, this is something very for contributing into the field of assisted reproductive technology. And at the National CME in Lucknow, which was held in 2017. We look forward to hearing for pearls of wisdom from you, Dr. Sohani. And
okay, thank you. Thank you for your kind words. And it's the greatness of the people who awarded the lifetime achievement, and nothing special to me. So can I share my screen now?
Yes, ma'am, sure.
Okay, so is it getting shared now or not yet? Can you see my screen?
No, we can't see.
No, ma'am, not yet.
So how do I go about that? My presentation is open here on my screen. It is opened. Can Atul or somebody help me?
Please share your screen. Please click on share screen.
I think Atul, you have the PPT of Dr. Sohani,
yes,
so please share. Huh?
No, just try with mine first. Why is it
Yes,
not?
yes,
It's open on the desk.
Yes.
So
Ma'am, please click on share screen button. There is a green color share screen button. So
that's why I'm pressing.
yes, please try.
Okay. I have pressed it, but not getting it.
So I'm sharing behalf of you. Okay, ma'am.
Okay, fine. So you'll have to.
Yeah, we can see now.
Okay, so
We can see.
But it's is it being controlled by you or me? Okay. Okay, can you hear me?
Yeah.
And can you see my screen?
Yes, ma'am, we can hear you.
Okay, that's very good.
Yes,
So
yes.
So at the outset, I would like to congratulate and thank the organizing committee, Dr. Ila, Dr. Jayesh, for organizing this wonderful workshop and to make me a part of it. So the topic I have to speak about is it the right time to plan pregnancy with ART? And to answer that question, definitely we have to understand the risks associated with the COVID-19 to mother and fetus. So we all know that the disease is caused by severe acute respiratory syndrome coronavirus SARS-CoV-2, and it is a very new disease, and therefore its exact impact, especially on pregnancy and fetus, is very limited, and mostly it is based on the case reports or the group of the case reports. But what we also know is that this virus belongs to the beta coronavirus genus, and we had already suffered pandemics in the past through the similar viruses in 2003, which was SARS-CoV, and in 2012 with the MERS, which is a Middle East respiratory syndrome COVID virus. And that time we had a lot more morbidity, mortality, and also the pregnancy complications. So we are all very scared about that, how this is impacting our current population. And therefore understanding and based on whatever evidence is available is very, very important. What we also understand is that COVID-19 is acute, immunogenic, thrombogenic, inflammatory viral disease. And therefore, we also know that pregnancy is potentially a vulnerable condition because of the physiological, immunological changes, such as there is increased heart rate, oxygen consumption in any normal pregnancy. There is decreased functional lung capacity, chest compliance, and altered T lymphocyte immunity. There is shift away from the cell-mediated immunity and also increased risk for thromboembolic disease. So with all this background, the couple who come to us, I think the questions they will have in their mind and also in our mind are, number one is, are pregnant women at increased risk of getting COVID-19 infection than non-pregnant? Are some pregnant women more at risk of than the others? And if they catch COVID-19 infection during pregnancy, is it going to be a more serious illness than in a non-pregnant condition? And our COVID-19 disease and its complications are more common and the patients are more vulnerable during any particular trimester? Should they just be careful in first trimester or something like that and they'll be all right? And can it cause to the fetal, can it lead to the fetal malformation, which is the biggest worry in all couples? And can it be passed on from mother to the fetus? So these are the questions, and we are looking into the answer to these questions in the available evidence from the reliable sources. So what do all these associations they are saying then based on the evidence? What does the Royal College option UK says? What they say they believe is that pregnant women do not appear more likely to contract the infection than the general population. They also believe that there is no good quality evidence to say that the disease will become more severe in pregnant women than in non-pregnant. But that is the view of the RCOG and based on the current evidence. Hello, can you hear me? Is there a problem? Oh, okay, fine. Whereas the WHO has a slightly different opinion. What they say is that definitely those pregnant women who are either older, overweight, or have pre-existing medical conditions such as hypertension, diabetes, will have increased risk of catching infection, and also they may have the severe disease and they may require, there is more chance that they may require care in the intensive care unit compared to the non-pregnant women. Now, United States, where they seem to be number one in this condition and having the maximum experience, unfortunately, what do they say is that when they are defining severe illness as hospitalization, admission to ICU, intubation, or mechanical ventilation or death, then what they are saying is that among the groups who are at increased risk of getting severe illness, they are including pregnancy there. So I think definitely the experience from the biggest, institution where they are keeping an eye and they unfortunately have a large number, says that pregnancy is a high risk condition. Even RCOG is a bit cautious, although say that they are not, they do not appear to contract infection more than non-pregnant. They are still putting the pregnant women in the group of moderate risk as a precaution. All they are saying, and they're not willing to accept at the moment that they are more likely to get serious illness, but they are not saying that it's a normal or low risk. 74% of the infected pregnant women are asymptomatic. Most will experience only mild symptom, and severe illness, the incidence is about 9% of all pregnant women who are infected with the SARS-CoV-2 virus. And severe illness is more common in the later pregnancy, and most women are hospitalized when they catch COVID infection in their third trimester or immediate postpartum period in the UCOS study. Now, the UK, what they have done is that their 3 early report on the maternal death confidential inquiry, which is now called Embrace UK, they published recently a rapid report on the maternal deaths in UK between March and May 2020. And in this report, what they identified that there were 10 maternal deaths which can be linked to COVID some way or the other. And out of these 7 maternal deaths, 7 died of COVID-19 direct infection, and 1 was probably also related to the COVID-19 infection. What is also more alarming is, just like Dr. Poonam Nair has spoken before me, is that they have highlighted 2 cases where the woman died by suicide, and where they have related it again to the restrictions imposed upon due to the COVID-19 conditions. And that's where these patients, they were either refused proper attention, or delayed, their referral was delayed to the specialist mental health care unit because of the restrictions related to the COVID-19. So that's very alarming and very unfortunate. The risk factors for the hospital admission in COVID-19 infection in pregnancy are Black, Asian, and minority ethnic background, where the risk is more than 4.49 times higher than in the non-pregnant women. Not in the non-pregnant compared to who are not in the BAME group. These women, when they are pregnant, they have 4.49 times higher risk. Also, if they are overweight, the risk is increased by 2.38 times. And also, if there are pre-pregnancy comorbid conditions such as diabetes and the chronic hypertension, the risk is more than double. Those women who are living in areas or households of increased socioeconomic deprivation, and also in addition, the people who are working in healthcare like nurses, doctors, or other public facing occupations like teachers and the social workers. Also, vitamin D deficiency has been linked with the higher incidence of requiring hospital admission and developing a severe illness if they catch COVID-19 infection. This is a report which is published by the USA every week, and when you look at that report, the recent report which they have put together all cases of symptomatic women of reproductive age group between January and October 3rd, and this was published on November 6, 2020. And what they identified that out of 23,434 symptomatic pregnant women, there were 34 deaths, compared with uh, only 447 deaths out of 3 uh, 3 386 to 028 non-pregnant women. So what they're saying is that maybe the absolute risk for severe COVID-19 associated outcome among women were low, but the pregnant women were at significantly higher risk for severe outcomes compared with the non-pregnant women. And this should be emphasized, and the couple should be counseled um, during all possible medical encounters, including prenatal care visits, and that will include when they're coming to be counseled for whether they should go for the ART treatment at this phase of time or not. And these are some of the figures which are quite scary, that if a woman is pregnant, then she is 3 times more likely to be admitted to the ICU, 2.9 times more likely to receive invasive ventilation, 2.4 times more likely to have ECMO treatment requirement, and the death is more likely by 1.7 times compared to a non-pregnant woman. And as you can see, the death rate is increasing so fast. So between, I think in the last 1 month, there have been additional more than 20 maternal deaths in USA alone. So coming to the age, I think it is also important. I think these pregnant women, they are all in the young group. So we are losing a lot of young women, I think, if they catch COVID-19 infection. So it cannot be simply ignored just by saying that they are not at increased risk. Now, more important is the trimester wise. And as you will see that because maybe most of the patient in first trimester may be having either asymptomatic or very mild infection, the patients who are coming to the notice and getting admitted or getting medical attention are more in the third trimester. And even the French study also says that pregnant women more than 20 weeks gestation were 5 times more likely to be admitted to ICU than those in the first half of the pregnancy. So the pregnant woman has to be careful throughout the pregnancy, and as a obstetrician, we have to be more watchful if they are in the third trimester of pregnancy. On the whole, the birth outcome, I think there is not much difference. And in theory, the cesarean section rate should not be high just because the patient is COVID-19 pregnant. Of course, there will be lots of mental and emotional pressure in continuing in taking these women for vaginal delivery, but they can deliver vaginally. And as far as the preterm delivery, some earlier studies did say that maybe preterm delivery chances are higher, but majority of the women did deliver after 37 weeks, which is reassuring. And just to summarize, based on that data, is that what are the specific risks? One is the VTE, as we know that pregnant women are always at increased risk of VTE, and this is multifactorial, not just due to the COVID virus infection, but also reduced mobility, and they are advised rest, isolation, staying at home, and other associated obstetric and medical morbidity. And as we have seen that there have been deaths reported in the embrace as well. And definitely one woman died of this thromboembolic event, and maybe second woman most likely due to the same. So it's very important to advise them while they are on self isolation at home that should stay well hydrated and mobile. And all pregnant women who are with the confirmed or suspected COVID-19 infection should be offered prophylactic low molecular weight heparin, and the dose may need to be increased in the severe cases, and it has to be continued for at least 10 days after hospital discharge, and maybe longer in some patients. Early miscarriage risk, there is no good evidence. Preterm delivery, as I said, there is contradictory report, and the large study says that maybe there is no increased risk. High cesarean delivery rate is there, but as per guideline, timing and mode of delivery should be dictated by obstetric indications rather than maternal diagnosis of COVID-19. One has to be very careful. COVID-19 infected patients do develop thrombocytopenia, and that time we have to stop aspirin if she was already on for some other reason, and thromboprophylaxis, and use the mechanical aids instead. Myocardial injury is a known complication, life threatening, and therefore early involvement of the multidisciplinary colleagues will be required in these cases. There will be treatment dilemmas, and whether they should be given all these medications, which are all on trial basis, and there's no definite curative therapy, as we all know that. And potentially effective treatment for COVID-19 should not be withheld. It should be shared decision making between the patient and the clinical team, and the women should not be excluded from clinical trials. Some trials have already been done, and they have suggested some modification in the pregnant women with better outcome. Like instead of dexamethasone, pregnant women do better when they are given prednisolone 40 milligram orally once daily, or hydrocortisone 80 milligram. But certainly the pregnant women, when they are hospitalized, they need multidisciplinary care. And mental health issues, that Dr. Poonam has very nicely pointed out, highlighted, that's very important to be monitored and managed appropriately. Risk to the fetus, there is no report of increased risk of congenital malformation, which is very reassuring. No evidence of increase in the stillbirth or neonatal death, no evidence of risk of miscarriage, and no evidence that fetal growth restriction is a consequence of COVID-19. Most of the babies are born in good condition, as many as 95%, and in the UCROSS study, only 2.5% of all babies had a positive test during 12 hours after birth. Breastfeeding is not contraindicated in COVID-19 infection, but all neonates born to infected mother must be tested and carefully clinically monitored. And the test should be done by through the RT-PCR, taking the swab from the nasopharynx, oropharynx, or nasal swab of the baby within 24 hours of age. And if the initial result is negative or not available, and if the mother was RT-PCR positive, the test should be repeated at 48 hours of age. Serological test is not recommended at this time, but what the studies have shown so far is that rates of COVID infection in neonates do not appear to be affected by mode of delivery nor by method of infant feeding, and nor by contact with a mother with suspected or confirmed SARS-CoV infections, which is reassuring. And this is again a slide showing that when they have done the test from the USA, again, a very small percentage of the women, of the neonates turn out to be positive, although their mother were RT-PCR positive for the COVID-19. So the vertical transmission is still debatable, but there is more and more evidence coming that yes, it is possible, especially when the infection occurs during the third trimester of pregnancy. The incidence has been reported between 3.2 to 6.3% in various studies. The evidence has shown that the COVID-19 can infect placenta, and the ACE2 virus, which has been identified as the functional receptor for COVID-19 infection, which is abundantly present in lungs, intestine, is also present in the placenta. However, although the placental positivity may be quite high, but not all cases there will be transmission of infection to the baby. So there are several unanswered questions at this moment, and there is one very good meta-analysis of vertical transmission. And again, the study shows 3.2% incidence of vertical transmission. And so it is possible, although it occurs in minority of cases, only those who catch infection in third trimester, and no assessment can yet be made regarding the rates of vertical transmission in early pregnancy because of the lack of data. So coming back to the questions we started to address, are pregnant women at increased risk of getting COVID infection? Answer is not clear, and we should still be watchful. It's in the moderate category. Yes, I think 2 more slides. And are some pregnant women at more risk? Yes, the patients who are obese, who have comorbid conditions, Asian women, vitamin D deficiency, yes, they are at higher risk. And is it a more serious illness in pregnant patient? Yes, it is, especially when they catch it in the third trimester. Can it cause fetal malformation? No, there is no evidence so far. Can it be passed from mother to the fetus? Yes, there is a small possibility that it may be passed on. So the final, this is my concluding slide. Is it the right time to plan for pregnancy with ART? Detailed counseling based on available updated evidence, which will keep on changing. We have to keep in mind it has to be individual choice of the couple. Assessment and optimization of risk factors such as the maintenance of the healthy BMI, regular exercise, vitamin D supplementation should be given to all women at this day and time with folic acid. Influenza vaccine is especially recommended during current pandemic. And the women who have already complex healthcare needs, I think they should be, I think, especially warned that it will be very challenging to manage them during a pandemic, and mental health issues must not be ignored. And the studies have reported even an increased risk of domestic abuse during this pandemic. And definitely there has to be strong emphasis on following all protective measures by the couple to prevent infection. And treating doctors need to keep themselves updated with new information and guidelines from reliable sources to help patients in the best possible manner. Thank you very much for patient hearing.
Thank you so much, ma'am. You covered the topic very nicely in such a short time. So I think we can take the questions at the end of the session. Now I request Dr. Parsuram Gopinath to introduce Dr. Rita Bakshi, ma'am. Sir, are you there?
Yes, thank you. I think it's a pleasure to introduce Dr. Rita Bakshi, who's done her infertility training from Singapore, diploma in endoscopy from Germany, and has also done a WHO fellowship at AIMS Delhi. She's a senior consultant, infertility specialist, and endoscopic surgeon, and also the chairperson of the International Institute of Reproduction and Fertility Training. She's also the chairperson of RISA IVF and International Fertility Center. She's got many awards to her credit, and currently she's a vice president of INSTAR. And looking forward to hearing from you, madam. Over to you.
Thank you, Dr. Parsuram, and thank you, Dr. Jayesh and Dr. Ila, for giving me this opportunity to speak on a subject, which is close to my heart. And I think coming nearly to the end of the session, most of things have already been covered. Now, the topic whether can third-party reproduction be considered during this time, this is something, which is, I would say, same as asking a woman whether she can become pregnant or not. So when we talked, when Dr. Sohani and Dr. Poonam Nair, who've done most of my work, said that, judicious, ask the couple. So I think there is where lies whether we can do even third-party reproduction. Of course, third-party reproduction has its own issues, which we will see how we can cover as we go along. So just to start the topic, and this was a joint statement by ASRM, ISHRE, and IFFS, and this was in May, when they said that this is an essential human right. So when they call reproduction an essential human right, and they said also that infertility is time sensitive and prognosis worsens with age, and nearly 10% of the couples, of course, are suffering and who require treatment. Well, this, of course, is a pandemic, and it is so unique because the infectivity and the mortality rates are so much more higher than, any other disease that we know of. And of course, in the earlier, when we started, all these societies nearly did say, recommend discontinuation, but more recently with, as time progressed, most of them have said that, yes, we can go ahead with the full reproductive care. So we are also acknowledging that subfertility is a serious disease and that requires treatment in a timely manner. Third-party reproduction, as we understand, requires a third party. That means either donor eggs, donor sperms, donor embryos, or surrogacy. And we understand that gestational carrier or surrogate is a woman in which the pregnancy is carried by someone other than the intended parents. So starting, it's nearly a year and we are still waiting for the vaccine and we are still waiting for the treatment. And these were the initial guidelines when they said suspend. They said suspend induction, IUIs, retrievals, FETs, as well as non-urgent gamete cryopreservation. They strongly considered at that time cancellation of all embryo transfers, whether fresh or frozen, but continue to care for patients who are currently in cycle or who require urgent stimulation and cryopreservation. So this was long back. Now, they did, publish certain basic guidelines to continue the fertility treatment and the good practices to resume reproductive care, and the 6 pillars of medical practice proposed for restart of ART clinic and lab, with the first one which said discussion, agreement and consent. I think here lies the crux of the whole thing. You discuss, you agree, you have a consent before you start any kind of treatment, whether third party or normal. And of course, staff and patient triage, advice and treatment, and adapt your ART services, plan your cycles and code of conduct. So when we give the offer of choice for proceeding or postponing ART treatment, and we have to document this patient preference. This is very important because whether we were doing surrogacy or whether we were doing donor, we were asking the couple whether they wanted us to continue or they wanted us to suspend or postpone the services. I will tell you how my experience has been, what happened and the percentage of people, what they did. But high-risk patients, we know who were diabetic and rest were anyway advised not to start with the treatment, and we inform patients about the risk and prevention. And as Dr. Neena and all the other speakers before said that they must sign and adhere to the code of conduct and agree to discontinue treatment if necessary. So this has already been covered, triage for both staff as well as patient. And, the moment you find whether patient or they are positive, you exclude them and include them only if they were triage negative. And this is how we adapted our services. Sanitation, of course, was one pillar and specific procedures were implemented. Staff work shifts and number of people who were important were kept, and limited access, appropriate distancing, all that in OPD, OT and lab were all done. and then follow up after 3 weeks for, to know how the patient and the people have been doing. No need to go back again, but we are all very familiar with all the triage questionnaire. And so we did. Informed consent process has become a very challenging issue before any and every clinical procedure during this COVID pandemic, because you really don't know what to cover in the consent and what not. So it has to be extremely detailed. And there is an increased risk of morbidity. Yeah, if there is a need for ICU anytime with patient undergoing a procedure, we know that there is a high risk of high mortality and unpredictable mortality if the patient has symptoms of COVID-19. So this is something that you have to say in the consent. Admission to ICU adds also to the financial burden, and there is an increased risk of perinatal anxiety and depression during this time. So the consent, ISAR, IFS, along with ACE, formulated a detailed consent form. And in the detailed consent form, before starting the treatment, these were the points, major headings on which they worked on. There was a questionnaire, there was a health screening, and how to self-isolate, how to adapt treatment planning, cancellation, cryopreservation, pregnancy, and counseling. This is how the form started with. That they have understood. There was a patient information leaflet, and they first and foremost went through the triage questionnaire, and all couples who are starting stimulation. So this is what they say. As all our previous speakers, and just to reiterate again and again, that all people have a different sort of, whether we are following ASRM or ASHRAE or IFS, it's our, so all couples starting ovarian stimulation on embryo transfer cycles will have a COVID-19 test on day 2 of the scan. So whether we were doing donor cycles or we were doing surrogate women, we were checking them on day 2 with an RT-PCR. And patients and their husbands having stimulation will have. Now, the husband part is, of course, a little, not sure, but this is what we were also following. Was patients and their husbands having ovarian stimulation will have a COVID-19 RT-PCR 48 hours before the anticipated trigger time. That is because, it does take around 48 hours for us to have the result. And before we could give the trigger, we wanted to be sure that they are negative. And patients as well as their husbands have an embryo, again, even on ET, when we started them on medicine on day 0, and the day we started progesterone, we were doing an RT-PCR test just to be 100% sure that they are not suffering from COVID-19. So this is what is the same thing we did for donors. Again, on day 2 of the cycle before stimulation and 48 hours before trigger. Similarly, for the surrogate, we were again doing on the day of the when we start her on day 0 and on the start of progesterone. So now, the whole thing about it doesn't matter whether we are doing third party or we are doing asking a woman to spontaneously conceive. What we are bothered is the passing of the virus in the sperm, in the egg, in the embryo, and finally the vertical transmission that Dr. Sohani just talked about. So, and since we will always have a conflicting data, but most of the data, what they were saying was the data presenting SARS-CoV-2 in semen was conflicting, but currently the FDA did not recommend testing prior to obtaining sperm for third-party reproduction. This is what the FDA said. The most current recommendation, however, ASRM, HRA, IFSSR were saying that do RT-PCR testing. So we will always be at crossroads to know whether we should be testing everybody who is giving sperm, whether it is a donor or the husband. Important is the cancellation of procedure. Egg collection, embryo transfer, freezing, thaw, biopsy, anything can be cancelled or postponed at any point due to a potential or confirmed COVID-19 infection of either of the partner. And consent regarding the cancellation should be taken before starting the procedure. In third-party reproduction also, it was the same, that the couple, the intending couple should know that if the donor, if you want to cancel, their cycle can get wasted. So we were taking this consent regarding the cancellation before starting the procedure. Well, the ASRM recommendation regarding the safety of surrogacy include consider the current, this is what they said, this is in July 2020, consider the current impact of COVID-19, where now, what I think was the logistics, the travel, I think was much more important than the whole talk about COVID. See, if we are asking a normal woman to conceive, so conception, once it has occurred, is same. If you are asking either we say no normal couple should conceive, because they can get COVID-19 and it can pass on to the egg, it can pass on to the sperm, it can pass on to the baby. But we have not done that because we don't know finally what will be the outcome. So what was important was the travel. I think where the intended parents and the gestational carrier or the egg donor live. For the first time, we thought, with the world becoming a globe, it was so easy to travel anywhere for parents to go. But right now, the travel part became the most important part. Of course, they said use frozen donor eggs. So they said, okay, don't try to get donors to attend. Use frozen donor eggs and sperm shipments for embryo creation instead of travel, especially when the donors and parents are, living in, in far off places. And document if a donor or a surrogate has had close contact with someone who has tested positive for COVID-19 or has had a positive test or has had symptoms associated with COVID-19. And donors or carriers who test positive should have their cycles cancelled. So I think this is, all in all, I made my talk really short because I just wanted to talk on these issues with surrogacy during pandemic. So the more legal and wider issues for parents and surrogate-born children around the world included logistical difficulties for parents who wanted, for example, I had parents coming from, say, even Haryana or Punjab. And I remember delivering this surrogate and, first with the states closing borders, it was very difficult. Not all states had the same kind of testing. So if I asked my Punjab patient, I remember this was in July, August to get an RT-PCR done. He said, ma'am, it is not so easy. I said, okay, Delhi is more open, so you come. So when they came, all hotels were closed. There was no place to stay. So I remember he's sitting in the car where, we got an RT-PCR done. And by the time the report came, it would take, time. And so he was sitting in the car because there was no place open where he could go to. So that is why I thought logistics were much more important than the issues that we were talking about, especially in cases of surrogacy cycles. So, and then, at that time, even the hospitals where we were delivering wanted a negative certificate for the intended parents. Not only were we testing the surrogate, we were testing the intended parents, both the husband and the wife, before they got admitted to the hospital, and they both had to be negative because obviously the staff didn't want to, and we were admitting. So in the way we do surrogacy, we do admit the parents to also learn how to look after the babies for 24 hours. We do want them to become comfortable before they. So this is what was the problem, when they were coming to pick up their children. So restrictive hospital policies limiting or preventing the parents from attending the birth of their surrogate child. Most parents do want to be present when the baby is being born, if it can be electively, or when closer to the dates. Most of the parents would travel and be around when the surrogates are delivering. So inability of those parents to personally assume care of and if the surrogate delivers and they are not able to travel. I know of one of my patients from Northeast, she could not travel and she could not come, and for 14 days, fortunately for us, there was a local guardian, who could take care of the baby. COVID times are such funny times, because at this time, even relatives, are when you are having cremations done without your children, it's very difficult to get people to assume responsibility of somebody, when times are different. So difficulties in obtaining the legal status, and see, we don't have a parental order, and in UK and other places, courts, these were also closed. So this was another problem in respect of surrogate born child, how to obtain the order. Then concerns about the health and welfare of the surrogate herself or the unborn child during the COVID-19 crisis. Now, where to keep the surrogate? Is she safer with 4 people in her own home, or is she safer with the 20 or 30 surrogates housed together? This is another, dilemma that we had, how to manage and what would be the safer alternative. So, and concerns, of course, about if something happened to the surrogate, if she tested positive and how to manage. Let me tell you what we did, here was that we started testing the surrogates at around 36 weeks of pregnancy. And every week we were doing, because from 36 weeks onwards, if we were allowing her to go in for a vaginal delivery, then we were testing her every week, because the test anyway is only valid for 72 hours. So, and if it was a cesarean, then still we were doing at 36 weeks, because I still had wanted to have enough time, at least for the 14 days, for her to become negative. And let me also share that out of around 40 surrogates that I delivered during this period, 3 of them were asymptomatic but tested positive when we tested them at 36 weeks. So fortunately for us, since they were asymptomatic, none of them became serious or required ICU. And we still had enough time for her to be quarantined and for her to test negative before we could deliver her out. We had also, contacted our centers nearby for, keeping ready in case. And our hospital that we were delivering was a COVID-friendly hospital. In case, they went in labor before that, and we had taken refuge in a hospital which was entertaining COVID-19 deliveries, so that, once only I remember in a surrogate delivery where 72 hours had passed since we treated her as COVID positive, as is happening in every single hospital, while admitting them, and we all wore PPEs, and we delivered her, kept her till the report came negative, and she was as any of the normal patients. So these were the concerns about the health and welfare of a surrogate or her child during COVID-19. And see, what we were doing, I would like to share also. So I thought the surrogates are safer in a surrogacy home, where they are ensconced and where they are monitored, and where we could, look at the sanitation closely, and where we could refrain them from moving around. So, but all to all, I mean, everybody has different talks on that. So the other thing was, in the beginning, I even remember my surrogate staying in Haryana, it was difficult to get her ultrasound done, because, she could not cross the borders. Borders were getting sealed here and then. And then parents entering a surrogacy arrangement. So, where we make the surrogate her husband, parents, the husband and wife, and the lawyers sitting all across. This was all difficult. This is all difficult, especially, in the times when we started, when even entering a surrogacy arrangement was not an easy thing. So change of circumstances of these, I think both surrogate and intending parents had to change, as we went along the time. And the dispute with a surrogate agency or a fertility clinic arising, well, all these also happen. There was uncertainty about continuing availability of a surrogate or donor. Yes, if you've chosen a donor and, something happens to her during the way, and unexpected. I think this is something, unexpected death of the loved one, whether it is a husband or wife, the intended parents, or the surrogate, and then what to do with the posthumous storage and use of eggs, sperm, and embryos in a surrogacy and fertility treatment setting. So this was important, and this I'm not sure. None of the our agencies are also giving us clarity on this posthumous storage. Whether the embryos which are remaining, if something happens from the couple, then does it from the sperm from the husband go to the wife or to the parents? And who has the right? So I think it is time, especially this pandemic has forced us to think on these topics much more closely. Normally we don't really imagine deaths, but this pandemic has forced us to come to these topics in reality, face to face. And it is time we thought about the posthumous utility of the gametes. So of course, these were, this became famous in Ukraine. The babies born to surrogates were stranded, and for a long time when travel could not be done. So to the intending couples, we obviously additional counseling and documentation regarding, we tell them now that COVID-19 and what are the effects on pregnancy and the developing fetus. Now, to tell you how many people stopped surrogacy and how many people continued. So out of the couples that I know, around only 5% of my couples said that we would like to wait till March 2021. And this I'm talking of is in March 2020. So they said we would like to stop for a year, and we would like to, probably by that time things would be more under control, and please continue our surrogacy at that time, keep our embryos frozen, and but this is only for 5%. 95% couples said continue. None of the couples, in fact, most of the corporate people who are sitting home came forward, whether
We
donor.
are running short of time, ma'am.
My last, okay. So most of the people forward for whether it was for stimulation, monitoring, retrieval, embryo transfer, or cryopreservation. And this I am not touching again because all of us have touched it. Frozen embryo transfer will be the choice of treatment. That is what they said. Recommendations for reducing the risk. I think we've covered most of it. So these were, because we were doing a lot of storage in these cases, whether it is sperm or extra care. Pranay has already talked of semen handling, closed systems, and offering ICSI. This was another thing they said, offering ICSI to all patients during the pandemic and culturing zygotes individually, because, you are still doing better washing, holding each sperm, so doing ICSI and individually, culturing zygotes, avoiding touching cryopreservation straws without gloves, and all this we have already talked of, and keeping separate liquid nitrogen storage. However, I can just say that doing all these, we have been reducing the risk to staff, potential. This is what I said in semen,
मैंने फोन से लेफ्ट किया है क्योंकि मैं लैपटॉप से लॉगिन कर रही हूँ.
So and similarly in eggs.
हाँ, और वो नहीं आ रहा है, बैकग्राउंड नहीं आ रहा है.
So this was vertical transmission. Dr. Sohani has just touched that more or less, I would say it is rare. So, and this is what gives us the safety and the surety to continue on on a topic like this. And so my conclusion would be that, yes, we leave it to the patient. We give them an informed consent. And then if they are okay with it, we continue doing third-party reproduction. Thank you. Thank you so much.
Thank you very much, Dr. Rita and Dr. Sohani, for this wonderful presentations and thought-provoking, which still leaves everybody, in a dilemma as to what should be done. I think we have answered the questions up to which Sanjeev Khurd had asked. There's a question: should we quarantine the donors as they may not give history of exposure. Also, it would increase the cost. So, how to ensure the donor remains negative after the stimulation has started?
So I think now this is true again, not only for a donor, for an intending couple. All that we can do from our side is we are testing them on day 2, they are negative. You have to tell her to be isolated. And as we said, no parties, no social, whatever you can. And this, as I'm saying, is not only for donor, this is for any normal couple. So you tell her, you can only counsel her and then test her again, as we said, 48 hours before trigger, to make sure that she has understood. I think that's where counseling has taken such an important
Center stage.
place.
It has taken center stage.
Yes,
Counseling.
yes.
Dr. Rita, there's a query that for the surrogates, if are there any legal clauses which probably will be added later on in case they develop COVID and COVID associated complications which would be life threatening?
I that is what I said, that right now we don't have, but and I would ask IFS, ISAR, all people to take up this, because this is very important now. Really do not have any long term. We don't know. There are people who are coming sick after 3 months of having, and then what do we do for the surrogates? Or and even the insurance policies. I think we have not really, we keep talking about it, but there is no insurance which are really in place for pregnant women yet. And in times like these, they are going to have precedence over everything else. So it is time at that, we all sit over and build up on this part now, not only insurance as well as long term complications which come. We say 6 months we look after, but now this should force us to look at it even more closely.
Any other questions, comments?
Dr. Sohani, or I would like to ask everybody whether, like, how to counsel the couple when they come and ask whether this is the safe time to plan for a pregnancy or not.
I think I think the answer again needs to go through the whole article, whole lecture which I have said.
No, we have listened to that, but
nothing is sure. No, what you're asking is very important as well, and not making it light. And but the question, the answer, final answer is we don't know really.
Exactly.
And it is very uncertain. We have to keep an eye open and we have to be cautious. And maybe the risk is not as high as we were anticipating or we were scared at the beginning from our previous experience with the SARS COVID-1 and also with the Middle East respiratory virus. It's not as bad. That time there were a lot of maternal death, miscarriages, stillbirth, and fertility was something like 10% to 35%. So it's not that bad, but even at this stage also to reassure that everything will be fine will not be really the right thing. And the answer is not in a straight line. We just have to give them all the information and ask them to make a decision and document it.
Could I ask, how do you counsel the surrogates?
So
because many of them probably come from a strata which may not comprehend the seriousness or the long-term effects, etc. So how does that impact our counseling?
I think, I don't know if you look at your patients around, I don't think this disease had, lower or upper or any strata. In fact, probably sometimes I realize it's more of the upper strata which has been affected, maybe than the lower strata. But when you are counseling, I think, and this is true for counseling otherwise also, they also understand that, if they contract this disease and the kind of way the money is given, unless they give us a good baby, it's all in parts. So they understand it as well, and they understand that keeping themselves safe is very, very important. But as I said, that we took the precaution of putting everybody in the surrogacy home, and where we were more sure, that they are not moving out, that they were, taking all precautions of sanitation, and where we could control the sanitation measures in a while. But I would say that counseling, and counseling, I think that's where the whole story would go about. If you tell them that, the disease, and I think media and everybody have made everybody very conscious and aware about this whole thing, and they are all aware about it. So I think that makes our task easier.
I would like to ask the same question, like, do we quarantine the donors as well? Because see, surrogates are there in the surrogate home, but donors, everybody, all donors are not there, and frozen oocytes are not available everywhere here in India. So how do we go about this for the donors?
So no, we did not quarantine donors, and I mean that would have been difficult. And seeing the number of donor cycles which are there, much more than surrogacy. But again, since we were testing them, that was the only way to,
But it would be very difficult to explain to the couple that, okay, now the donor has come out to be positive, so your cycle is cancelled.
No, it was not. No, it's not difficult. I'm telling you, because it happened with us 2 or 3 times that we had to cancel at the last minute. So it has happened, and I think people understand now. People do understand. So I don't think that is difficult.
That would be okay. Thank you.
Great. Any other comments?
I have a small query, and that is, if you have to cancel a oocyte recovery, you don't cancel a delivery. Why do you have to cancel a oocyte recovery? Why can't you complete it once you're saying there's very little chance of vertical transmission, and the oocytes, even whether they made embryos, can be safer? Why do you have to cancel for 2 days? You don't cancel deliveries. So I don't think this is justified to say now, after 4.5 months of having restarted our IVF clinics, that just for 2 days in want of having to complete, even if the patient is at 38 weeks, if you find her first time positive, you will still deliver her. 36 weeks leave apart. So why for 2 days you would cancel a cycle? Why not recover her oocytes and then let her recover, and any type of anesthesia or sedation or paracervical block could be given to that poor girl, rather than leaving her in a lurch on day 10 or 11 of her cycle, saying 2 दिन की वजह से हम cycle cancel कर रहे हैं आपकी क्योंकि COVID हो गया है. So please keep this in mind. I'm just giving a pointer.
Yes, thank you.
We are doing deliveries, cesareans, we are doing DNCs, we are doing even ectopics, laparoscopies, whether COVID positive or not. I mean, that is life-threatening. And here that poor girl is stimulated, and maybe 1 or 2 days are left, and we just drop the cycle saying that no ART. I mean, just consider it. It's a point to consider.
Thank you, Dr. Abha. I think you brought out a very, very valid point, and it is, you know what, probably why this is that we have a chance. At 38 weeks, you have no other option. You have to deliver her out. Here, just because you have, and you still are not, let me say, not 100% sure whether passing it into the meats is probably the only reason where I can think. But I'm very happy that you brought this point out, and I'm happy that coming from somebody like you, it gives a lot of credence to this whole topic.
Can I come in here?
Yes,
And
yes.
Dr. Abba, the difference here between conducting a delivery and oocyte retrieval is that delivery is conducted in a special environment. There is a dedicated COVID theater, there are dedicated staff, there is everything. So you cannot move your embryology lab to the OT, and the OT, there is a very special type of air filtration and exchange system there. So to make all those changes in the OT where we are doing the egg recovery may not be possible. So maybe it may not compromise the woman and the baby, but it will definitely compromise the staff who is going to do it. So that also has to be considered.
And more than that, we know the second thing is we know about the baby. The vertical transmission rate is only 2.5%. So we are very sure about that. But about the transmission of the infection to the eggs and to the embryos and to the other things, and the baby is born, we are not sure about that. We don't have research data about that. So we have to be cautious about this thing. I don't think we should be jumping on to doing
Dr. Abha,
if
you are
the patient
muted.
gets positive.
I want to make another comment here. Even when we do a RT-PCR and we find it negative, we still wear a PPE because we know 30% could be falsely negative. Just the technique of taking RT-PCR, I don't know how many of us have got it done, but the way a real technique involves is you almost gag every time. It's not easy to have a test done because it has to be taken from the absolute inner side, and people also sometimes take it from the endotracheal tube to get a correct report. So in any case, every patient whom we are operating today, we whether the COVID is negative or positive, we all wear PPEs, we all take protection, we all maintain distance, we don't do too many patients together. In our recovery, if there are 4 beds, only 2 are filled up at a time. So you see, those precautions have to be taken. And Dr. Sushma Sinha, regarding transmission to gametes, we have more knowledge rather than transmission to babies, because babies have been found positive. Gametes are these days thought not to really transmit the infection anywhere, even though someone is positive, you need a different closed system of vitrification to sort of store the embryos, maybe in a different can or same can, wherever. I mean, it's not practical to say different can for every happening, but maybe a can which is dedicated for your HbS positive patients and all, in a closed vitrification system in a different tube where just one sample is there, where there should be about 20 or 18 samples. So there are ways. All I'm saying is, as ART people, we have to go on changing with times. We have changed from what happened in March, that we had to suddenly shut down, then slowly we started opening up in July, and today Rita is taking so many surrogates, and I'm very happy about it, that one has to develop according to how the disease is evolving and how the knowledge is coming in. So there has been a very big knowledge gap when we started in March, but the knowledge gap has become much smaller now when we've reached November, December. So I'm just giving a suggestion that on a drop of a hat, we say of dropping cycles, cancel a cycle, a stimulated woman. And we do have to take cases thinking that, RT-PCR, and then Rita said 2 days. In our hospital, it is 5 days. In other places, it is 7 days. So what do you know has happened between those 7 days? Who has been exposed? And maybe after doing a oocyte recovery, 2 days later, we might find her positive with symptoms also. So I'm just saying, give it a thought before we have a knee-jerk reaction of canceling our stimulated patients. That's all, not other patients. You cancel other patients, it's all right. That's okay.
Your question is very thought-provoking, Dr. Abha. But what I said was that because it all started in December last year or November last year, and we, for few months, we were not doing IVF. And then we started doing, and then we started freezing the embryos and the eggs and everything. So from the frozen gametes, we haven't had many deliveries so far. So we don't know the data about that. This is what I wanted to say, that we don't have data about the infected women having their embryos or the gametes frozen and then later on delivering after the transfer. So we don't have data. I just said that. I didn't say that, yeah, we don't have data at all about the eggs and embryos and everything.
Another thing, ma'am, which I would like to comment is that before embarking on ovum pickup, we must also do a complete profile of COVID. Suppose she has an altered D dimer or an IL-6 level, so that is also very important for her health. So therefore,
practicality.
For now only, yeah,
Yeah.
RT-PCR is the one very valid test for now. Yeah.
So
I
no,
think so.
no final answer.
I think so. We are having a lot of discussions on the panel and the same
Yeah.
questions which was generated by Dr. Abha Majmudar. So I think so. Those who are as a chairperson, also the good senior people can still stay, because we can get your opinion also during this panel discussion if time arises. So I request Josna to just go ahead our next panel,
Yes, sir.
which is on 12. Yeah.
Thank you, sir. First, I would like to thank our chairpersons and the speaker from the last session. It was a wonderful session. And now we'll move on to our session 4, which is a panel discussion. It's my pleasure to introduce our mentor, Dr. Abha Majumdar. Ma'am doesn't require any introduction. She has many feathers in her cap, but one of them are like she's a director IVF at Sir Gangaram Hospital and she's a past president IFS. Then Dr. Jayesh Amin. Sir is a secretary Gujarat chapter IFS. Sir is a clinical director Wings IVF Group Hospital present in Ahmedabad, Rajkot, Kenya and Surat. And let's start with the introduction of our panelist. So first is Dr. Raja Priya Ayappan. Ma'am is basically a consultant at Srinivas Priya Hospital and she has a 25 years of experience in OBGY. Dr. Jay Mehta, he's a director at Shri IVF Clinic, Mumbai. Dr. Desai, Dr. Sanjay Desai, sir is the current head Wings Hospital Rajkot, owner of Pile Maternity Home Rajkot, owner of Pile Medicine Rajkot. Dr. Monica Singh, ma'am is an associate professor at Bhopal Hospital. She has a special interest in infertility and she's a OBGY. Dr. Bharti Joshi, ma'am is an assistant professor OBGY in PGI Chandigarh. Dr. Nidhi Sharma, she is senior consultant and IVF specialist at Jindal IVF Hospital, Chandigarh. Dr. Ashima Arora, she is a associate professor OBGY, PGI Chandigarh. Dr. Paresh Makhwana. Dr. Paresh Makhwana is an ASRM certified embryologist and a chief embryologist at Wings Hospital, Ahmedabad, and rest of the other branches in Gujarat. And we have an expert panelist, Dr. Neena Malhotra as well. So let's start with the panel discussion now. Over to Jayesh and our ma'am.
Hello. Good afternoon, everybody. We've just hit the clock at 12 now. And I would start sharing my screen right from now. And I'll tell you how are we going to take up this panel. We have two moderators, Jayesh and me, and we have 8 panelists. I think Dr. Rosa Rossetti has been replaced by Dr. Paresh. Am I right?
Yes, madam. But Dr. Roja Rosati, maybe Dr. Neena Malhotra will join laterly 12:15.
No,
So
that's
as a
all right.
clinician, that's right.
But you took
Yeah,
Dr. Paresh's name, which was not there in the original list.
He is a embryologist, so we can have a one embryologist to answer.
All right.
Yeah.
So if you can you see my slides, everybody?
Yes.
Yeah. Okay. And can you hear me?
Yes.
All right. So we have made our panel divide into 4 groups, 2 each, so that every question goes to one panel and we have very little confusion then. So group 1 is Raja Priya Jay Mehta. We've got good senior persons. Sanjay and Paresh will make group 2, which has a question regarding the embryology lab also. Then Monica Singh and Bharti Joshi, group 3, and Nidhi Sharma and Ashima Arora, group 4. Now we would start, when we start our panel discussion, one question Dr. Jayesh will take up, second I will lead to a discussion. So we've got 4 broad case scenarios, which were real life scenarios which arose during this pandemic when we were treating our IVF patients. And then the last 4 are again 4 questions which come up to our mind arising from all the discussions we had since morning. So all those 4 will go to again group 1, 2, 3, and 4. So if this is clear, I can move on to the presentation.
Yes.
And well, we are talking about IVF during COVID, and this is experience sharing. We will have difference of opinions and we will do differently. All we want is safety for our patients, safety for the unborn child, and safety for our staff. World Health Organization declared COVID-19 outbreak a public health emergency of international concern in January 2020, even though it started in 2019, and it was declared a pandemic in March 2020 on the 20th again. As of 22nd November, I've taken very recent data now, more than 58 million cases have been confirmed with more than 1.38 million deaths attributed to COVID-19. Look at this picture and see what happened in March. I mean, on the 23rd of March, after WHO declared COVID-19 a pandemic, everything came to a standstill. And this is from a very, very busy clinics in Spain and Italy. What happened on World IVF Day in September 2020? Okay, COVID was coming towards us, but we had started making umbrellas for it. And what does Indian Express write? It writes that there was compromised IVF access to 90% of couples, and the cases dropped very severely in between April to June. Just about 1,000 patients sought IVF treatment. So there was a steep fall in the number of patients from 50,000 to about just 1,000 in a quarter of a year. And then now comes the American Society for Reproductive Medicine. I saw what Dr. Rita Bakshi had stated by the ASRM, but this is an update on the November 17th. Let us see what they are saying. The ASRM has advised clinics to be flexible and recognize the status of their local transmission rate, medical conditions, and any impact that reopening their doors may have on their community. So our first priority is to see what our community incidence, prevalence of the disease is, and then only to reopen our doors. It is also advising continued caution with all embryo transfer cycles and IUIs included, because these lead to pregnancies. Since there is a lot unknown about how coronavirus may impact a pregnancy and the unborn child. However, the ASRM appears a bit looser in these restrictions and seems to have left this up to the judgment of individual clinics and their local governments. As a result of these loosened ASRM guidelines around coronavirus, most fertility clinics have reopened and initiated treatment. So this has happened from July in a more robust way. And now what is happening today is most clinics resumed IVF from July onwards, and thus the age of our experience of working with COVID-19 in ART centers is just 4.5 months. Let us all together find saving situations, find the tube which will help us swim out of this sea of pandemic. With this, I open up my panel, and I pass over the slide to Jayesh. Please,
Yes, yes, ma'am.
these are real life
So,
conditions, so please see how you would have managed this. Group 1 is responsible for answering this question, and if you remember, Group 1 has, I'll just repeat who's there in Group 1. Yeah, Dr. Rajapriya and Dr. Jay Mehta.
Dr. Jay, ma'am.
Yeah.
Yeah.
Okay.
So welcome to all the delegates, and really, as Madam says, this is the 4.5 months or 5 months experience according to the demography. I know Madam is also in Delhi. I'm in Ahmedabad. We are the very hot pandemic affected areas, especially for the COVID-19. And I know that when we started something in the March, when there is a lockdown, we all are worried about that how we can start. And there is a lot of the webinars of how to start and how to start. And now I know that everybody started, and everybody doubts are clear that patients are coming. So that first query is already resolution on the way that patients are coming. Now how to manage, that is the most important part. That is what by our experience and what are the test or modalities available. So looking to that, without wasting time, this is my first question to the first group of the panel, that control ovarian stimulation for IVF started for 30-year-old female for unexplained infertility, and 8 days of stimulations given with a good response. Husband is tested positive for COVID after becoming a symptomatic. Couple staying together, SCG triggered due within 2 days. Now, I want to ask that question is for the panel is there. One is, how will you proceed? How will you proceed for this patient? So cancel or continuations, and if couple does not agree cancellations, what precautions from oocyte retrieval to freezing? What are the legalities of proceeding out for cancelling and counseling the couple regarding the impact of COVID-19 on pregnancy and her baby? And does COVID-19 affect the gametes? What does evidence say? So these are my all questions. So we'll proceed for the first group. How will you proceed? This is my fourth question, that how will you proceed?
Yeah, Jayesh bhai, first of all, am I supposed to answer this right now,
Yes,
or Dr.
yes,
Priya is
yes.
supposed to answer?
No, any
Yeah.
one of you two. You can
Okay.
go on
Okay.
adding up.
Right. So thank you to IFS Jayesh sir and Abba madam for having me over. Now, actually, I'll straight come to the point as regards to this question. Now, first thing, this is very common in a city like Mumbai because of the density of population. So this eventuality which Jayesh bhai mentioned, that on the day of the trigger, the husband has tested positive. So what we've started doing, and we were doing this since quite some time, is that even before the treatment starts, we have the sample for the husband frozen when they come for the counseling before starting the treatment. And ever since the pandemic, actually, we've never had the husbands coming over to the clinic on the day of the oocyte collection. We've never had the husbands giving the sample on the day of oocyte collection. That is predominantly to reduce the load in the clinic, because space is a big constraint for IVF clinics here in
So
Mumbai.
excellent. Move on to the next answer. This is a very good answer.
Hmm.
But if you don't have the semen, what do you do?
Right. So if we don't have the semen, then at least in my situation, I'm going to freeze the oocytes, and I'm going to ask the husband to come over after a month or so and give the semen sample back to us.
So there's another situation because they are living together. So we have to look at whether there are separate rooms so the isolation of the husband can happen. Of course, I would also have that standard backup freezing done at the beginning of the cycle when we know they are not at risk of COVID or the swab is negative. So that's the way we go. But this is 2 days prior to the trigger. So I would be definitely looking at keeping the ladies safe because we don't know if contact has happened. So we need to understand that there is a time phase between contact and developing symptoms. So there is a timing of the swab so that we know that the swab picks up or not. So I would have, obviously the legalities would have been like proper counseling and taking down a consent with respect to COVID-19 as to what is the policy of my clinic with respect to proceeding or cancelling the clinic. So I would request her to stay in isolation from the husband. And if she is symptom free, like it's only 3 or 4 days before I'm going to give the trigger and do the OPU, I would go ahead, pick up the eggs and freeze. But if she has become symptomatic already, then I would go ahead and cancel the cycle. So it's depending on how she's going to present on the day of trigger.
If she's not symptomatic, will
I
you
would go
repeat a test for her on RT-PCR on the day of trigger morning?
Yes, I would do it on because I know that she's within the contact period and it's my standard policy to do the single RT-PCR on the day of the trigger.
And
That's
if
what
you
I
get
said.
the report and it is negative, you go ahead, and if it is positive?
If it is positive, you have given a good response. So I would have to see if she's at risk for OHSS or not. Like if it's just going to be around 6 to 8 follicles, I would have to go ahead cancel the cycle if she is looking symptomatic, because end of the day her safety is more important rather than the OPU. So, but if she's at risk of OHSS, then I would have to follow a OHSS protocol of giving antagonist and
Right now we haven't reached that situation. We've not given a trigger. She's asymptomatic but RTR positive. Jayesh, you ask her the questions.
Yes, madam. But so what I'm saying that if do you have any conditions in your this all 4.5 months that you have a trigger and if it becomes positive, what is your decision at that time? Are you cancelling or are you something going to start and doing pickup? What you had done and what type of consolations or what type of legal responsibility that you explain to the couple? What type of consent you are taking?
Jayesh bhai, the question was if the husband is positive, right?
Yeah.
And now it has shifted if the patient is positive. So are we, right. So if, see, as we already mentioned about the husband being positive, if the patient is positive, then there is only one thing which we do at our level. We cancel the cycle irrespective of anything. Okay. And we inform the local BMC office as per our directions, because the BMC has very strictly asked us to notify. And the other thing which really happens and which is pretty unfortunate in the IVF clinics, even at our end or even in any other IVF clinic, is it leads to a lot of tension in the staff, because quite a lot of times the patient has come for doing an ultrasound. So of the last 2 months, I think we've closed our clinic down 2 times in the last 2 months. And now what we've started doing is, once the first injection or once the protocol is made, we ask the couples to do the ultrasounds outside, so that the only second exposure the only second exposure is on the day of egg pickup. Trust me, because otherwise it's a nightmare to manage the staff. I think it's very, very difficult to manage the staff. Forget managing the patients. It's very
So,
difficult in such situations.
one last comment, Dr. Rajapriya, Dr. Jay,
Yeah.
everyone, on does COVID-19 affect the gametes and what does evidence say?
Evidence is uncertain and unclear at that point, and I think that's one reason we are all sitting and continuing and to restart practice. I would definitely not cancel the clinic if she's asymptomatic. I mean, if she's RT-PCR positive, a good response, we've counseled her, say she's one time chance for her to get that many follicles, I would go on an individualized decision, because here in Chennai we have managed to have not much of damage because of COVID. It's relatively in control. So if my anesthetist agrees with precautions of PPE, we would go ahead and do the pickup and freeze the oocyte. She's asymptomatic.
Oh, excellent. I'm very glad that you brought in that it is area wise also. What Jay will take as a decision would be different from what you would take, Rajapriya, because the incidence is different in both the states. So
And the
this
virulence.
is what the evidence says. I just brought this slide here. In fact,
Yes.
Jayesh put this slide here.
Yeah,
That there
yeah.
are only 2 studies which say that no transmission happened. One study says that yes, they found, but it is probably the DNA which remains in the semen and not the virus. So probably infection may not be there. So this is a little data here about the studies, that what does evidence say. Jayesh, you can read all this, please.
So now let us check what is the evidence says that to date 5 studies have identified no virus in the semen, 91 patients total infected with COVID-19. That is all in 2020, Wu et al. And Hartman et al. In 2020, Pan et al. In 2020. These are the different studies. While this data is very, very reassuring, manuscript mentioned the presence of virus in the semens of 6 patients infected with COVID-19, in 4 in acute phase and disease, and 2 are cured. That is what in Lee et al. In 2020. So most of the patient, what we can say, 91 patient that's showing, but these are the last, this 6 patient is a little bit worried about that there is a presence of the virus in the semen also. And now we can say something, cycle cancellations, when and why and how to manage. I think so. This is a question, madam, that we can generate to the same panelists, that there is a cycle cancellations, when, why, and how to manage.
This I think Jay Mehta is going to answer, because he said irrespective of everything, we will cancel the cycle.
Right. Okay. And what about the Raja Priya Ayappan? You are also going to cancel the cycle?
Raja Priya very clearly said. Yeah.
Okay, fine.
Yeah. Raja Priya very clearly said she will continue if the patient is asymptomatic, and whether her RT-PCR is positive or negative.
Positive or negative.
But Jay is going to tell us what he'll do, because ASRM says if cycle has been started, postpone further treatment after cycle completion.
Okay.
Right. So, no, I would, to be very honest with you, I would still cancel it.
Okay.
I am going to cancel the cycles irrespective of what ASRM says, because to be very honest with you, if something goes wrong, then the entire onus comes on us. The entire onus comes on the clinic. So, and that time the ASRM is not going to come to save me. Definitely.
So
ASRM will be sitting.
I'm very glad you brought this forward. So 2 of our panelists staying in different areas of India go on the same opinion that yes, wives should be tested before, they should be kept separate, but the only thing is that one will cancel because of the status and the fear of legality. The other one thinks that it is safer to go ahead in case the patient is asymptomatic.
Because ma'am, in a pandemic, the couple are coming forward. At the initial consultation itself, we give them the option. If you enter the program, this is the deal, or you stay away for the program for another 6 months. Because once they've entered the program and we have signed up to do the program, we should try to make an honest effort with available evidence to complete the program.
Correct. I agree with you completely, but I also agree with Jay. And Jayesh, I think you also would agree. But then, Jay, if the patient says that I am asymptomatic, I have no problems, even if the test is positive, why do you not do I'm going to go to the court? I wasted all this money and this time in such a serious pandemic. I went to the ultrasound clinic. I exposed myself to so many places. How would you answer that legal problem? The patient
Yeah,
says that.
I know, madam, that this has happened to me. In fact, this has happened to me include 3 to 4 times already in the last 6 months.
So patient has threatened you that you can't stop my cycle because I'm asymptomatic, right?
Yeah, they have see, it's for a patient who is asymptomatic, it's natural that, you know, when somebody has spent 2 lakh rupees, they are going to threaten you that, you know, you cannot cancel this way, and you know, you have to do
And the
something about it.
RT-PCR can be wrong.
The RT-PCR can be absolutely wrong, and they are
Yeah.
absolutely right in saying that.
Yeah.
But what typically happens is, I always tell them one thing: you put yourself in my position, okay? And if in case you are having 5 other patients, and if I tell 5 other patients on the same day that, look, this chap is RT-PCR positive, now we've done everything in our board to take care of everything, but don't worry, you will have a little risk, so don't worry, you know. And that is something in my initial few days
So
when I
where is
started.
distancing? Where is distancing, Jay Mehta?
Exactly. There is nothing
5
called as
patients
distancing
you
in
can't
Bombay.
take in one day.
I know, madam, but there is nothing called as distancing which is currently happening in Bombay. So, in fact, I'm more scared about continuing the IVF program in the last 1 month than I was when I started in the month of August. You know, that time people were scared and they were listening to everything. Now they think that now vaccine is coming, so please do everything. So, to be very honest with you, though I am on this panel, I am extremely scared of continuing IVF, you know, in such situations, because people are not listening at all in the city of Bombay.
Correct. This is also in the city of Delhi. People are not listening. They've celebrated Diwali and Bhai
In
Dooj
fact, as
in
we
full.
do this panel, I'm waiting. I'm going to the police station because I have been called to the police station because one patient has gone and complained that their father, okay, he's filed an FIR against us that their father caught COVID because the husband was asked to come to my IVF clinic and they've caught it from the clinic. So fortunately, the police has, you know, they've not taken so much this thing, but I'm just supposed to give a counter to them. And this is the situation.
But Jay, this is in the consent form. We always write this.
Despite that, yeah, madam, all the consent forms, no. I've got one thing I've realized in this entire pandemic, no. Even if you do a video consulting and video counseling and all these things, they will only save you, okay, if you are able to present all this to this appropriate authority. Otherwise, all these things don't really help.
You
People
will
are
get out
crazy.
of it because if you've written in your consent form that you will not hold the clinic responsible, they cannot hold the clinic responsible. It is their own risk that they want to go through IVF. You've not pulled them from their houses to come and go
But
through
madam,
IVF.
all this, no, to be very honest, all this is theory. You know, when somebody wants to go and do something, they will go and do it. You know, and police, no, remember one thing, no disrespect for any police officer, but police sees this as a very good opportunity to get butter from both the sides. I hope you understand what I'm saying.
Okay, now we come to case number 2, which is almost similar to the first case, but the scene has changed. Here, a woman with underlying PCOS was undergoing COS with antagonist protocol for IVF. As per routine protocol, was asked to have COVID-19 RT-PCR on day 7 of stimulation because our protocol in our hospital is that within 5 days, the patient of anesthesia, the patient should have had a RT-PCR cleared. Whether you've done it initially or you've not done it initially, but 5 days before the anesthesia is required. She hyper responded to COS with more than 3 leading follicles, more than 17 mm on day 7 of stimulation, serum E2 levels of 2200. Ovitral trigger was decided for next day. Now, COVID RT-PCR was sent because she was asymptomatic, but somehow the report could not be ready till the evening, and we got the report only in the morning because ICMR people have to come and sign the reports before they are released. So this was after the trigger was already given to her. She tested positive for COVID-19. So I would want the second group now to answer this. And the second group has now Dr. Sanjay Desai and Dr. Paresh.
ऋषि कौन से फ्लोर पे? ऋषि डेढ़िया कौन से फ्लोर पे?
Thank you, Dr. Abha. Myself, Dr. Sanjay Desai.
Yeah.
Yes.
So your questions are, how would you counsel regarding
Yes.
complications?
Yes,
Number one, of going ahead with COVID-19 during OCR, or if we cancel or don't cancel, then OHSS also. Because she's
Yes,
already
madam.
received a proper trigger.
Yes, madam. We are in the phase of pre-COVID and COVID era. We can divide the world into two segments, that is pre-COVID and COVID era. COVID era is what I mean to say. It's a walking on a rope. Any change, any deviation can result into COVID infection. And as already said, for this patient, for carry on ART treatment in any patient, we should have a special counseling department for a couple to discontinue the cycle at any stage of the treatment, looking to the safety of the patient, the couple, and hospital staff and our lab. So, looking to this patient, we are in dilemma either to go with Dr. Rajapriya or to go with Dr. Jai.
Correct.
Yes, but as already trigger has
What
been
will
given.
you do? What will you do? How will
Yes.
you counsel the patient regarding OHSS if you don't do a aspiration or pull up of oocytes? Is the OHSS going to be more severe?
Definitely.
And if you do a OCR, then what is the risk to your staff, to the patient, to the anesthetist?
Yes, advisable according to my judgment, it is advisable always to discontinue the cycle, looking to the infection in the lab and looking to the risk of the staff. But as the patient is likely to have OHSS, we need to observe the patient with all antagonist and everything.
Okay.
And we can observe the patient for a week or 10 days.
So you will cancel the cycle, right?
That is more preferable as compared to the taking the risk of SPT.
Dr. Sanjay, are you going to inquire the history and inflammatory markers to the patient that to give a chance of having a pickup? Suppose she is asymptomatic and everything.
We can.
Is there any
counsel
second alternative that you can? My patient is saying that I want pickup or like that.
Yes, we can go for testing COVID profile. If all parameters is normal and patient is psychologically prepared for getting pickup and looking to the risk of OHSS, then we can have a calculative risk as said by Dr. Rajapriya for getting pickup. But at that time, it is always advisable to keep other patients away from routine procedures in the lab.
Dr. Paresh, will you answer this part? Will you want to fertilize her oocytes? Just a minute, all this, fertilize or not? Whether you'll want to freeze the oocytes. Suppose you go ahead. You've thought that asymptomatic patient and I don't want such a big risk of OHSS. And will you freeze the oocyte or embryo? If you freeze, where will you freeze? And when will you take the patient next if you cancel the cycle?
Yeah, thank you so much, ma'am. If my clinician cancel the cycle, then there is no question. But if we continue, if we continue the cycle, then definitely we will go for the OM pickup. And we all know that the zona pellucida is a protective coat for the oocyte. There is no receptor for this virus, so you can proceed for the oocyte. But at the time of OM pickup, you have to keep in mind that the patient is already positive, so you have to do with the proper PPE kit, and you have to maintain all the equipments and whatever you are using disposable there, you have to manage it. And one more thing,
Are you using a PPE kit for all patients in the embryology lab today?
Not in all the patient, ma'am, but if it's a positive patient, then we go for the PPE kit.
So it is RT-PCR which
and
decides.
One more thing, we yeah.
Not
and
the
we
pandemic.
have to wash the we have to wash the cumulus or oocyte for multiple times to decrease the viral load. And after denudation, we can go for the ICSI also, because once we did the pickup, there is no meaning to freeze the oocyte because the male is not positive, negative. So we can go for the ICSI. We can do the embryo freezing. We will not transfer the embryo in the same cycle, and we will do embryo freezing, and we do the freezing in the separate container what we are maintaining right now. And
Dr. Sanjay, are you doing the male testing before egg pickup again?
Yes, that is a routine thing.
You are doing it. When do you do it? When do you do it?
If patient is positive, then it is advisable to very soon investigate the husband also for RT-PCR and CT scan also.
But otherwise, you don't do it routinely before you.
It is not a routine procedure. Yes, it is not a routine procedure.
So everything depends on the wife's RT-PCR, asymptomatic both. But if one RT-PCR comes positive, you would want to do the husband's. Okay.
Definitely.
All right. There is. Suppose they found viral binding receptors, then what you said, Paresh, you can read out this, because this is what they do in livestock embryos where they wash many times Wash and wash. This is
Just
what
to
you just
decrease the
told
viral
us.
load.
Yeah, if there is any over it. What changes have you done in your IVF lab in the post-COVID-19 era now when the work is picking up in almost 60-70% work has picked up in most labs? So what are your changes in the IVF lab? Just main things. I don't want the general thing which goes on. What are the most important changes? Because somebody told me, how can you do a pickup in the IVF lab? But then we had to make changes in those 3 months when the lab was closed, so that IVF lab doesn't have higher risk than other places like the OT where you take up patients. So what changes would you do in your IVF lab?
And the
What did
most
you
important
do?
thing, we have decreased the personal load in the only 2% are allowed during in the laboratory, and
Okay.
The strict cleaning protocol is allowed. And one
Okay.
more thing, regularly screening of the employee as well as the patient.
Okay. How regular? How many times have you undergone a COVID testing? How many times have you undergone a COVID
I
testing?
went for ma'am 3 times actually
Okay.
RT-PCR.
Okay.
Basically, he's my chief epidemiologist at present in Wings. So I know that his family is infected, and we make him away for 7 days because his family is infected. He has been tested before to arrive in my lab,
Okay. So
and
he
we
was
have a
tested. He was tested because his family was infected, not
infected.
because he's
Yes.
working over there. Because practically every 7 days, having all the employees do RT-PCR is not really
So just we have to check for
possible.
the symptoms and that temperature only, ma'am, routinely.
Madam,
So
there is, I'm interfering only, Paresh, that
yeah,
we that always answer what we are doing practically.
yeah,
Practically, nobody in the world is doing. If you are
yes.
asymptomatic, then why there is a need of a test? That's
Very
it.
correct. This is
And
what I
by
want you, we all to tell what are we doing, because we don't do unless we have a exposure, family member or a colleague falls positive and we've been
yes,
working with the colleague, then we go in for a testing, but not as a routine. We have a RT-PCR for the whole staff, like you said. So please don't say theoretical answers. In this panel, we want to know, because I don't do. I have never got a RT-PCR till now
yes,
because I've never been exposed to anyone who was positive. My junior staff has got it done many times because they are dealing with positive patients, the deliveries or surgeries. This is one important thing which I thought we all need to do. Air handling units to be switched on all the time to create positive pressure, so
Definitely.
that, this is very important, which we
important.
have done in our OT, and therefore we do not fear doing a positive case in our OT at all.
Oh,
Yes, in the embryology lab, we could not have this possibility because they said that it'll mean that we will have to change the whole embryology lab. But in the main OT, we have it, and we only have a hatch through which we pass over our tubes. So I think this would be a very good, like you said, movement of embryology should be minimum. Flushing media droplets for washing gametes has to be more for all, even if our patient is negative, because we have to treat everybody as positive.
yes.
And if you have to vitrify, then probably this is the system which you
Closed
would
system.
use. Do you agree with all
Yeah,
this?
Yes,
definitely, ma'am, with closed system.
Closed system. So please just highlight everything. But most important is air handling units to be switched on all the time in the OT. And these OTs should be as safe as the other OTs to handle COVID patients. We could
So
not
my
have, we
okay,
could
madam.
not use one of our OTs which had less air handling exchanges. We had to put that in place, and then we started using one of our OTs. But otherwise, we have 22 OTs and all are equipped with this, and our IVF OT was already equipped with this, except 2 OTs which were in our epicenter, which we had to change. So I think we all need to do this.
And if the lab, those who are not having air handling unit, then what they can do? Is it something they can
It is the
close, or they can
OT. It is the OT
OT?
mainly. It
I'm
is
saying
not
the
the
OT.
lab.
No,
It is
I'm saying
OT.
OT because the lot of IVF OT also don't have air handling unit
They
still
need
in
to
India.
put this into place in their centers. They need to put this
Yes,
into place. Otherwise, they are at risk. The staff
yes,
is at risk. Everyone is at risk.
yes, yes.
Yes, madam.
So I
Now,
think so. We can
Sanjay, you
move
want
on.
to add something, Sanjay?
No, that is all thing that has been included. Thank you, madam.
Anything else you want to answer in this? Anesthesia, what type of anesthesia would your anesthetist give, Sanjay?
It is short general anesthesia routinely.
Okay, but here, once the patient is positive?
That will be the same because it's not possible into local anesthesia.
Okay.
So we'll be implementing the same anesthesia, but anesthetist will be aware of the thing and will be taking care of all the
any of our clinicians have a different view? All those who are in the panel, maybe some different type of anesthesia?
Yeah, spinal anesthesia can be given.
Yes, ma'am.
Yes.
We should be avoiding general anesthesia.
Yeah.
Spinal, it can be done under spinal anesthesia.
Correct. I go totally with you.
Procedures under spinal anesthesia only. All routine pickups.
Did any of my panelists ever have the need to go ahead with such a patient and give spinal anesthesia?
We haven't.
Did anyone have the need?
Sorry, we didn't get your question, ma'am.
Did anyone really have the need where a patient was positive, you went ahead with her pickup and you used spinal anesthesia? Because I have not done that till now.
No, we
it is only theory for me.
We are using spinal anesthesia for all pickups because we are avoiding general anesthesia exposure to the
Very good. Excellent.
But not, we don't have any exposure of COVID positive patient being picked up.
Right. This is a very good statement, Nidhi. And I'm so happy to get this answer that you're doing all your pickups under spinal anesthesia in this COVID era, because RT-PCR positive or negative, we treat everyone as positive. So the OT should be well equipped, the anesthetist should be safe. And if these two things are good, then nobody out of your staff will get it, especially if the embryology lab is separate and there are just 1 or 2 persons in the embryology lab. Correct?
Yes, ma'am, definitely.
So now the next question goes to Jayesh again.
Yes,
yes. Group 3.
So group 3, I think so consultants of group 3 are ready for the case number 3. And the case number 3 is a couple with mild oligoasteroid reduced spermia underwent 4 unsuccessful cycles of IUI and post-wash count of 20 to 30 million per ml. And now enrolled for IVF at our center. All investigations of pre-IVF found normal. Husbands had COVID-19 following enrolling for IVF. Now, couple came after 1.5 months to start control ovarian stimulations for IVF. 1 day of oocyte retrieval, semen sample showed on the day of oocyte retrieval that sample showed azoospermia, and TESA also performed but no sperm retrieval.
Now we have Monica Singh and Bharti Joshi to answer these questions.
Yes, ma'am. May I start?
Yeah, sure.
Yeah, if we see the history, this man has definitely oats, but when we did the
question to the panelists is that
yes,
hello?
Go ahead, please.
Go ahead.
To be some signal problem. Okay, ma'am. So the thing is, because there can be a transient oospermia seen in case of any acute viral infection, and this is going to last at least for the cycle 80 days of you need to observe any semen cycle for that. So it is expected that this virus can have induced oospermia because previously we have found that he has some semen count. So now it is the counseling which has a significant role. We need to explain that it may be a transient. You may return to that level after some time. So we can give him a chance actually for this.
Okay. So there is a viral viremia, and we know that we need to counsel the patients regarding the chances of azoospermia. I think so. You all people are making a 1 sample prior to that, but might be not available. Then we can go ahead. So my next questions to that: if couple does not agree for donor semen, what you will do? If couple does not agree, suppose that couple does not agree for donor semen after TESA, azoospermia, you don't have any semen sample there, and if couple does not agree.
Nidhi and Monica, I just want to bring one thing forward. That excellent. We have now learned from our experience that azoospermia can happen after COVID infection fever or any other fever. And therefore, what Jay Mehta said, that standby semen samples are becoming more and more important in today's pandemic. So now Jayesh has put up the next question, and I would want you to answer it.
So the second question already says you don't have a semen sample. Actually, not all we are accepting a fact, and this is a routine practice for all IVF clinics that one semen sample should be standby, even pre-COVID. But now, if you have a don't and azoospermia, no sperm retrieval, then what happens?
Can I answer this?
Yeah, sure.
Ma'am and Dr. Jayesh, in this case, after being diagnosed positive for COVID, the couple had a 6 weeks gap before starting the cycle. And I think before the oocyte stimulation started, the husband did not test for a sample. Otherwise, we would have come to know the status of the sperm count and possible effect of the virus viremia on the count. So this couple gave the sample right at the time of just before the pickup.
Yes.
So that's when we came to know of the azoospermia, and they are not ready for a donor semen. So it's better to just freeze her oocytes and wait for maybe 2 or 3 months and then test again for the husband to be ready for giving the sample when hopefully the sperm count would be better.
A very nicely brought in, because this is our learning curve, that now we are getting more cautious that everybody should have a standby sample. And this is after this case happened in July that we were like, whoo, what happened? A person, and but 3 oocytes again makes a very poor
Output will be there. So
output for
ultimate,
freezing
yeah.
oocytes.
So now about this all the
Because it
third
will put
question.
up the cost also, it will put up the a false sense of security also, and maybe we might get very little out of these 3 oocytes 3 months later when the husband's semen count may come back.
Yes, ma'am. So that ways the counseling has to be
Has to be
done,
there,
with a
right.
little bit of negative counseling.
Yes.
And probably wait for things to be better. And if she doesn't get a positive result with such a low quantum of oocytes and a next semen
So
sample,
maybe
then
you
probably go
can
for
even
a
counsel her to discard the oocytes and not put the cost of freezing of oocytes, and then again ICSI, and then again,
yes, ma'am. That is
IVF charges for these 3 oocytes when you thaw them. So negative and positive counseling both need
has
to
to
be
be
done.
done, and it is ultimately patients, the couple's personal decision, which we have to respect and
How
follow.
you explain the
Yes,
patient, that
yes,
is
ma'am.
also very important.
Very
And
important.
in both ways, you have to explain the prognosis of just 3 oocytes, because these are real case scenarios which we had in July, and that opened our eyes towards so many problems which we could have.
Ma'am, here I just wanted to ask our respected moderators, what is the status of the thawing of the oocyte, the vitrified oocytes? What's the status in India as of now when we freeze them? How are we retrieving them? How healthy are they?
Who's asking this question, please?
And ma'am,
Monica sent
Monica.
it.
Monica.
Monica is asking it.
Monica, from where are you?
I'm from Bhopal, ma'am.
So you
Bhopal.
tell us your experience. You are the expert panelist.
In MP, in all over Madhya Pradesh, oocyte freezing is not being done very frequently, ma'am. So we are not getting very good results in thawing as well. I'll be
You've
very
answered
honest.
your own question, that negative and positive both counseling need to be done with just 3 oocytes, because a lot of cost will come over to the patient.
So it is all depending on the Dr. Monica, what you can we can counsel something. It is all depending
Be
on the
truthful,
age also.
just have to
Age
be
of the
truthful to your patient about your results. And then you can even go for negative counseling and say don't get them frozen, because it will add so much cost, and we have very poor results with frozen oocytes.
So basically, it will be a
I have
cancelled cycle. It will be something like cancellation. In you have proceeded, but you are still cancelled
so
after
San,
negative counseling.
You just discard the
I
oocytes actually.
Yes.
Yeah,
Taking.
not cancel. You've done
I
the
think so. I think so. The ideal answer, madam, that will be something like that. The center, the organizers, those who are really having a good oocyte program freezing, and if they are doing routinely, they have a media and everything is ready and they're prepared. The
Yeah,
center
so
like that
every
and
center will
patient.
answer
Yes,
honestly about them.
yes.
Yeah.
Yes. If they are the organization, they have their own data and they have good output, they can freeze the oocyte also if patient is affording, and counsel that okay, the extra cost we can have a cryo accumulation pooling, because if you show the 3 oocytes, so we also believe that this female might have a very low AMH, might be possible. What will be the chances of the retrieval the oocyte in the next cycle? So we can counsel on the both sides, but it depending on the organizations that how we are. If the organizations is not having any experience previously, this is their first freezing, and if the freelancing embryologist is there, I feel it is always discard the oocytes and go ahead for the next cycle.
Nowadays, freelancing has become minimal because of the traveling restrictions. So we'll go to another question, which we already read, that yes, Sertoli cells do have the SARS-CoV-2 receptor, and therefore the virus does bind to them. And Sertoli dysfunction is the one which leads to absolute stoppage of spermatogenesis. But then we have a similar case, number 4. Here again, it's on male infertility only. It is, just let me read it. Another couple came living in Agra. Agra and Delhi are very close, connected by the Yamuna highway, which is just takes about 2.5 hours. In their mid-30s, came for their 3rd IVF cycle. They had undergone 2 IVF cycles at our center for tubal factor infertility and already have 1 child old from the 2nd IVF attempt. All routine tests conducted for both partners. Both were normal. Male was normal, female was normal. Couple registered for IVF, came back on day 2 of wife's menses. 1 month later, as husband had fever for 20 days, was treated for typhoid in Agra, and now was normal for the last 10 days. COVID-19 was not tested during fever as diagnosis of typhoid was made, but when they came and we started the IVF cycle, we did the test, it was negative. But then again, we had the same thing. Controlled ovarian stimulation with antagonist protocol done, and day of OCR, no sperms retrieved as the semen sample showed complete azoospermia. So I would come back to the 4th panel to answer this.
Yes, ma'am, but we have already discussed, as we all know, any kind of fever would affect the sperm
but see,
count.
this is so nice that you told us. I never thought that any kind of fever would bring complete azoospermia.
Actually, before starting any IVF
So
cycle,
if we have that history, we would do the counts before starting the stimulation at all.
So how many of my panelists always have a standby semen sample in their centers?
Yes, always. Before
Yes.
Start of the program.
And then what do you do to that semen sample later on when you are doing the OCR on that day, if the man is able to give a fresh sample?
We discard the sample once we use the fresh sample.
You discard it?
We discard it.
But
are we beforehand?
Does this have any legal implications that to discard it immediately, or do you write in the consent that we will discard it?
Yeah, we do write in the consent. We'll be taking that sample for the temporary usage only, and in case we get a fresh sample, we are going to discard it.
Very good practice. Who's answering this question?
Madam,
Dr. Nidhi and us.
Nidhi, okay. Because I think this is a very good thing, Nidhi and Ashima, that you're doing this, because we were not doing this. I mean, we go on keeping samples, and at one point of time, we are like full of samples, and then we say, okay, you are okay, give a fresh sample. But I think this is a very good practice.
This sample before the start of the stimulation is only as a backup if the husband is not able to give a sample on the day of pickup.
So we are supposed to discard it.
Yes.
Right. What I'm adding something to all the panelists, that what we are having a strategy since, I think so it is more than 15 years in this field now. So we have on the first day, we have a strategy, and which is still maintained on this 2020. I don't know that's post-COVID or pre-COVID. But what we are doing something, the freezing the semen sample, one semen sample is always freezed. Second, the thing should be, we are charging the patients for continuing the semen freezing for next 3 months. So they can have a charge, and we can have a consent that we are going to discard the semen freezing after 3 to 4 months, whatever the 3 months, 6 months, we are going to charge them. And third thing, what we are doing that if the semen sample is less than 10 million, so bad semen sample, always explain that you required always freeze semen sample, even you are having the freeze semen sample. That is what our counseling
let our panelists give us their opinion. Ashima and
Ma'am, in PGI, in PGI, as a routine, when we start a stimulation, on the same day, the lab person in the microscope sees a fresh sample of the husband under the microscope to avoid any last day hitches like this.
Yes.
Because in PGI, we are not freezing for everyone like Dr. Nidhi is doing in their center. We are not having a frozen semen sample for everyone. But when we start the stimulation, we see the husband sample there and then in the lab under the microscope, not a thorough, maybe a theoretical report, but the sample is seen and only then the stimulation is started. Ideally,
but a lot
it would
of
be
men have so much of glitches in giving a semen sample every time on demand that, men always make faces when we say that please give
But
a
so
sample.
is the counseling. It's the way
Yes,
we
ma'am, but
counsel the
yes.
patient. We
Then
always
canceling the cycle.
What
Yeah.
Jayesh was saying that if this counts are low and we're doing it for male factor infertility, then having a
Then
standby becomes absolutely
Yes, ma'am.
essential.
It would be ideal to have a standby
But
for every
others,
patient at least.
if we start having, then we'll have maybe 150 samples a month, and every month, if we go on collecting and keeping it, even for 3 months, would be a big liability.
Yes, ma'am. We are not keeping for
And
everyone.
the consent goes for the immediate disposal after the
Yeah.
use of fresh sample. And in case the couple wants, our husband wants it to be frozen for later use, so we give
We
them
have
the
extra
option.
payment. Okay.
Yeah, that is a
This is a
different
very
issue.
good
They pay
suggestion
for
by
it
the
and then they
panelists.
keep it for next 6 months.
So I think we will take this up and we will ask everyone to start using this method that you take a standby sample and consent to dispose it off unless the couple wants on an extra charge.
Yeah.
That would be very good.
And this has saved us actually during COVID era also, because we have also come across a kind of case when the husband came out positive after giving the initial sample once when he was negative. So we went ahead with the oocyte retrieval, used his cryo-frozen sample, which we had collected earlier when he was negative, and then went for the embryo freezing. So that way we could save the cycle.
So one thing, no, Nidhi, before doing a freezing of sample, are you doing in this COVID era RT-PCR?
Yes, ma'am. We
So
are doing.
y'all are doing lots of tests, you know.
We are
इसी
doing
के
it
test
twice.
कम पड़ रहे हैं लोगों को.
No, ma'am, we are doing twice the RT-PCR, once before starting the cycle, and once the couple comes negative, we start the cycle stimulation for the wife, and we take the frozen sample, backup sample from the husband, and then again we are repeating the sample before a day or two of HCG trigger, and accordingly we decide whether we have to go ahead.
So you do a husband-wife's RT-PCR on starting. You take the husband sample, freeze it, go ahead with the wife's COS, and then 2 days before you again do both.
Yes, ma'am. Both.
Now I will ask Nidhi that
Any panelist or anyone has a question here on this, that how many times can you have that stick into your nose?
Yes.
And the cost?
I would only want to add.
Ma'am, even how the counseling goes, ma'am, none of my patient has actually objected to this.
Yeah.
No, Dr. Nidhi, I can say something that what is your experience then you are doing a 4 sample for a one couple. Suppose you treated 4 times. So suppose you treated 100 patients, just saying that 100 patients and asymptomatic. What is the positive ratio?
No,
that
and
you
then
could
will your hospital allow you to do so many tests? We are not allowed. We don't do a test on the starting of COS.
No, ma'am. We
are doing. We are doing. We are also doing.
We are not doing it on freezing. We are not doing on analysis. We are not doing on fresh. We are only doing one COVID testing for the wife. And if husband is symptomatic, then we do a test. This is all we do, you know.
No, ma'am. Actually,
because if we do 150 cases a month and then cryo embryo transfers is another 80, we will have, I don't know, maybe 500 tests or maybe 600 tests just for the IVF center. What will the other hospital do with all emergencies and all other cases admitted?
That's
it's a big load. It's a very big
I
load.
belong to Chandigarh, where the case positivity, I mean, the peak, we haven't seen that kind of peak which you people are seeing in Delhi and Mumbai. But still, we have made it a protocol to remain ourselves safe and for the safety of the patient.
Okay, so if you have the means, you will do all the tests. But if you don't have the means, you will still do it before semen freezing. And then you tell the husband you stay in a different room, let the wife stay in a different room.
Yeah, maybe.
Anything anyone has to add to this? Sanjay Desai,
Jai Mehta,
Jay Mehta, Nidhi,
Paresh, what is your suggestion?
Monica, Bharti.
I can say all panelists, any change in the semen freezing technique that you have changed in your IVF lab by your embryologist or andrologist? Any change in the semen freezing technique? Are you doing the same that previously, or can we do something? It is really advantageous. Paresh, can you say something about being an embryologist?
Before COVID, actually, what we are doing is when we are taking the backup sample, where we are freezing the raw sample. But after COVID era, we do that density gradient in all of the semen and do freezing.
Okay. So this is an important thing again, which Paresh has brought forward, but I'm just bringing good options, which my panelists told me to do. We thought this after we suffered our problems. Repeat semen if any fever and standby frozen sample, good option as routine protocol in all patients, especially during the pandemic. So all of my panelists agree on this. We are running short of time, just 5 minutes left for the panel. So
Yes.
these are 4 questions to all the 4 groups. Group 1 can answer first after you've read the question. Then group 2, group 3, group 4. Please answer these and short answers so that we have a take-home message for all this. First question is, do you recommend, Jayesh, will you read the question now?
Yes, yes. I will ask the first question to group 1.
Do you recommend RT-PCR for COVID-19 trials?
Do you recommend before or during ART cycle? If
So
yes, when or do you wait
you've answered this,
for
but
already
then,
answered?
but group 1 can answer this.
Practices currently we are having around 500 cases per day. So in Chennai, currently what I'm doing is it's only COVID triage questionnaire at the beginning of the cycle, and a single sample is taken just prior to semen analysis for the husband and prior to on the day of trigger for the wife, and we get our results within 6 to 8 hours. So
Semen analysis or semen used for IVF, Raja
before
Priya?
the standby semen freezing, once it's taken, ma'am, that's it for the husband, and once for the wife before the trigger.
Okay, you know what we were doing, Raja Priya? We were not even doing it when we were freezing samples. We were only doing for the wife, husband only if there were symptoms. We were using his semen without doing a COVID test. We were freezing it or we were using it.
We are
So it's
also,
good
madam,
to know.
like that.
Okay. So anyone has now group 2, Jayesh?
So group 2, the next question is about like, do you recommend RT-PCR for COVID-19 or trials to the man during couples ART cycle? Already answered, but and when and how many times do you do it? Him frozen or fresh semen and COVID-19 RT-PCR testing before semen collection. So we already discussed, but if somebody is having
donor
any
recipient
donor
cycles, what do you
cycle?
do?
Yes, Dr. JS, routinely we are keeping a backup semen sample at our lab at the starting of the cycle. And if a husband is asymptomatic, that is not a routine protocol in our lab to go for RT-PCR for a husband at the time of getting a pickup. And we do collect the
donor recipient, what do you do? You keep
Pardon
a
me?
frozen sample before freezing. Do you do RT-PCR for husbands?
No, that is not a routine in our lab. If only patient is symptomatic, then only we go for RT-PCR.
Yeah, even we don't do RT-PCR before freezing a sample.
Yes.
So what is the take home from this from you is, Sanjay, that you
Yes,
don't recommend before freezing a sample?
I think COVID is running very fast, so it will not be practical also to go for RT-PCR very frequently.
Yeah.
It will be adding on the expenses to the patient also.
Yes.
So asymptomatic patients, ideally we should avoid the recurrent testing.
But triage is very important,
Very
whether their
important,
family
yes.
member has it or not,
Definitely.
and whether someone with whom they are living has a positive.
We must have proper history of the patient and his family.
I think we have to put the fear of God into them, that if you give a wrong history, your semen will be affected, your child may be affected. So please do not give us a false history that anyone has COVID positive in your contacts and you have not told us. So we have to counsel them to make them afraid to give a correct triage form filling.
So now we are moving to the third question, which is also we are discussed, but I want to hear all from our panelists that what you people are doing. If you are planning for FET transfer, freeze embryo transfer, are you doing RT-PCR test to the female or not?
Or a triage,
or a triage, whatever you are doing.
Sir, we are doing a proper triage.
Group
So
3
group
will
1,
answer
I think so first group 1.
No, group 3 will answer this later on.
Okay, group 3 will answer.
Yeah,
Sir,
ma'am.
Okay, sorry.
Okay. We are just doing a proper triage for the couple before the FET cycle, not doing the RT-PCR testing. If the patient has no history, no symptoms, they are perfectly healthy, counseled, we proceed with the FET. No RT-PCR. Bhopal has got a low positivity rate. The state services are excellent over here, and our area is practically, free. We are very lucky, blessed that way. So this couple undergoes a triage at 3 stages: first at the reception, then the clinic staff, and then personally by myself before we take her for an FET.
Yes, so this is a good message that we are also not proceeding for any RT-PCR in our clinic
Anyone
also.
else? Group 3 has one more.
Yes,
More
ma'am.
person, yeah.
We have an institutional protocol that any kind of intervention we are doing RT-PCR before that, because our experience in any patient who is coming to us in emergency is that 98% of the women who tested positive were asymptomatic. So in that way, they didn't have any kind of history, but most of them were positive, and they remained positive that we delivered. There were missed abortions, there were ectopics, there were gynae patients. So as a routine intervention, there is an institutional protocol that for any kind of intervention, we do RT-PCR.
This is this Dr.
PGI
Bharti?
Chandigarh. Yes,
Bharti,
PGI Chandigarh.
from where are you? PGI Chandigarh.
Yes, ma'am.
Okay.
Even we are doing RT-PCR before any kind of transfer, whether it's frozen or, of course, fresh. We are not doing, but frozen transfers, we are doing routine PCR.
Yeah, I'm sure you will be doing, because you are doing 4 RT-PCRs before a oocyte retrieval.
No, this time we're testing only the wife, ma'am, just once before fixing her transfer.
I know in 2-3 months again our policies will change, Nidhi, because the disease is taking a big jump. Delhi cases have increased so tremendously that all the medical forces and RT-PCRs are going towards diagnosing real cases, following them up, rather than absolutely asymptomatic patients who are entering elective procedures. So anyways, and the last question is that in a IUI cycle, what are you doing? And the fourth group will answer this, Nidhi and Ashima Arora.
Yeah, for the IUI cycle, we are a little lenient this time because we are doing only triaging of the patient before taking for the IUI cycle. We are not doing any COVID RT-PCR before semen handling.
Why your staff is not dear to you over there?
I would differ on that. We are doing a single RT-PCR on the patient. Like, see, PGI is a dedicated COVID hospital. So initially we had shut down infertility services for some time. Now we have restarted for a few months, and IUI is done. Initially only teleconsultations were started. Now physical infertility treatment has started. And for IUI cycle,
are you doing RT-PCR? When are you doing it, and for whom are you doing it?
Ma'am, we are doing it only for the patient. We are doing only selected IUIs till now. That also after thorough counseling. We would prefer the husbands not to attend the clinic.
No, but they will give a semen sample for preparation. No, the lab personnel is going to do the same processing as it is done in the IVF lab.
Ma'am, Dr. Nidhi had told they were doing RT-PCR for the husband twice. In PGI, we have not restarted our IVF cycles. We are doing only IUI cycles, that also selected. So we do a COVID-19 RT-PCR for the patient before the IUI cycle. We are not doing for the husband. And we prefer the patient to get the sample.
You're not afraid of having the husband infected asymptomatically and the gametes carrying it to the baby and the baby being born like you have for IVF cycles? Why is this fear more for IVF and less for IUI? Both are interventional, both have personal, both need a lab technician to prepare the semen. In fact, semen handling is more in IUI rather than IVF.
Yes, ma'am. That is why things have been started in a very phased manner. Very less number of cycles, very selected patients, and a RT-PCR for the wife. The IVF cycles we have not restarted till now.
Anyone else wants to give an opinion, because we've shot up with the time on this, that in IUI cycles, right? I heard from Chandigarh you are doing it.
We are not doing the RT-PCR. We are just doing a triage questionnaire at the beginning of the whole program and before he gives us a IUI on the IUI day. However, if we look at the proceedings of the day, RT-PCR is mainly being done for two reasons in our center. One is medico-legal aspects of safety, and the other is the concerned team, whether the anesthetist comes in, his safety and things like that. And semen freezing is because that sample is kept amidst other samples. So mostly RT-PCR is more in the sense of medico-legal and with respect to staff concerns.
Okay.
Otherwise,
so you are doing RT-PCR before taking semen for IUI?
Pardon, ma'am?
Rajapriya, are you doing a RT-PCR before taking semen for IUI? Or
No,
just
ma'am.
triage?
No, only triage questionnaire. No RT-PCR for IUI cycles.
legally we will all be safe if we have a good form of triage fill and the patient's signature on it, because the patient is fully responsible to give us correct information. And if they have hidden any information, right now I think this pandemic is handled so well by our government that every information goes to a central data collection and every patient's information is with the government. So if the family member has and he's not written, then it is totally his responsibility for giving us wrong information.
Yes.
I think so, madam. We are running short, so we can just
Yeah.
go ahead for the annual. So you can just
we can just go with this, that we have done third party reproduction, I think was already spoken by Rita Bakshi, and we will change our approach and adapt as the world fights the virus. Let's see, we will after 3 months have a panel again, and maybe we might come out with different conclusions. We might reduce the RT-PCR or we might increase it. We might go over to triage like all European countries are doing, or we might maybe not have the pandemic anymore and we would be safer. Jayesh, you want to say something and we'll finish off?
nothing else. So at the end of the outset, I thank all the panelists and especially my mentor, Dr. Abha Majmuda, for creating this panel so interactive, because I know the madam is so dynamic and taking all the questions in such a way that the carry home message is going on. And we hear something, a different part of the different area. I know that different part are doing the different demographical part and they are having some certain SOPs. But lastly, the message is going on. Most of the panelists are doing a liberality on doing a COVID PCR test in the certain like FET, semen analysis, and only female testing of COVID PCR during the IVF procedure. So we are ending with this all carry home message. And I thank to all my mentor, my coordinators, my co-coordinators, my MOCs, and the organizers, those Chandigarh organizers, committees, everybody, and panelists. Thank you so much for participating, and much more. Thank you, Dr. Ila Gupta. Especially thanks because she made a lot of efforts to help it out me also. So thank you so much for making this successful COVID workshop. Thank you.
Thank you, Ila, Jayesh.
Thank you, Dr. Abha.
Thank you.
Thank you, Dr. Abha, Dr. Jayesh, and all the faculty members.
Thank you.
Big thanks to Dr. Yogita, Dr. Josna, and not to forget
Thank you, madam.
Sumit,
Thank you so much.
Atul, and Tanvi for so well coordinating the workshop. And it was a very smooth run, very informative. So thanks all of you, and see you very soon. Thank you very much.
Is this the last session? Is this the last session?
Yes, ma'am.
Yes.
Wow, you finished so much in time. I can't
Yes,
praise you
yes.
better. We also tried, but my panelists were great.
Yeah.
What honest answers I got,
Yeah,
and I'm
yeah.
so glad to get honest answers, because this is what a panel means. Everybody tells their clinical practice, and later on we review ourselves at the end of it when we go back that we must change. We decided to change.
I think
our
so. It is
semen. Yeah.
It is an announcement for quiz or not. Jindal madam says there is a quiz is there. So after this session, so that's why we are in the hurry to complete this session.
Okay.
So after this session, there is a quiz session, and it is also so important to refreshing our knowledge, that how we are updating our knowledge by taking from the outside. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you, Dr. B.N. Chakravarti, for inviting me. It was an insightful projection of the importance of maintaining the T helper 1 and 2 balance and its impact on the in vitro fertilization success rates. Hello friends, I'm Dr. Amit Patki. Today we will discuss the practical implications of Lotus 1 and Lotus 2 trials conducted with premenopausal women between 18 to 42 years of age with documented history of infertility. The aim of Lotus 1 and Lotus 2 studies was to substantiate the empirical use of 30 milligrams dydrogesterone 10 milligrams administered 3 times daily for luteal support in IVF, and to demonstrate non-inferiority to 600 milligrams of micronized vaginal progesterone 200 milligrams administered 3 times daily, or 8% micronized vaginal progesterone gel, which equates to 90 milligrams daily. The results demonstrated that oral dydrogesterone is a viable alternative to two main types of micronized vaginal progesterone, either gel or capsule, for luteal phase support in IVF patients, and dydrogesterone may replace micronized vaginal progesterone as a standard of care owing to its patient-friendly oral administration. Both the progesterones had comparable safety and tolerability profiles. Overall, the robust Lotus 1 and Lotus 2 studies identified no new safety concerns associated with using oral dydrogesterone, and no link to congenital malformations could be identified. Therefore, dydrogesterone has the potential to induce a paradigm shift for luteal phase support in the estimated 1.5 million women undergoing IVF each year. I was fortunate to be part of the Lotus 2 trials and an initiator for both Lotus 1 and Lotus 2 trials. These trials were conducted not only in Europe, but in Middle East, Far East, India, and China, taking a large amount of population diametrics into concern. I think the Lotus 1 and Lotus 2 have firmly established that dydrogesterone can replace a micronized vaginal progesterone in luteal phase support in IVF treatment owing to its patient-friendly oral administration. I now hand over the session to my fellow colleague who will speak on the story of frozen thawed embryo transfer and the missing corpus luteum.